everybody, and welcome to the annual English Diabetes Foot Care Network conference, again online this year. I hope that we've got a really interesting and exciting agenda for everybody this afternoon. The way it's going to work is we are going to have the various topics, discussions and presentations, and then there'll be some time to ask questions afterwards. So if you can use your Q&A for questions which maybe we can answer online, or the chat function will be able to ask questions directly of the speakers. And so I think without any further ado, let us move on to our first speaker. Our first speaker is Ruth Woods. Advanced podiatrist. She's going to share the process of implementing the National Wound Care Strategy Programme's recommendations for care in community-based podiatry. Ruth, who specialises in complex risk, will discuss how over the last 9 months, City Healthcare Partnership has been applying the recommendations. The sessions will also cover how it has impacted on the organisation's future plans for non-diabetic foot care provision within Hull and East Riding area. The aim of the session is to increase the understanding of the need for non-diabetic foot ulcer care in England, the importance of data collection, and how the NWCSP may impact on future workforce planning. Many thanks.
Thank you, Richard. Oh, there we go. I might have got somewhere. Sorry, apologies. It's come back on again. It's basically to set out the improvements for NHS England to improve the care and prevention of lower limb wounds and reduce the unnecessary variation in care. So this is the current UK situation. We have as many non-diabetic foot ulcers as we do diabetic foot ulcers. And this is mainly due to the lack of clarity with the pathways for the non-diabetic foot ulcer patients. We all know in the last 10 years, there's been a lot of funding towards the diabetic foot ulcers. And with the NICE guidelines implemented, they've got the fast track into specialty care with vascular, orthopedics, etc., and timely, which, as we all know, increases good outcomes. And that pathway just has not been there for the non-diabetic patients. Meaning that we've now got similar numbers for both cohorts, but the pathway's not the same. So the National Wound Care Strategy Plan is really set out to decrease that variation in care between the two cohorts of patients and really bring equality to all patients with foot ulcers, regardless if they're diabetic or not. So the background locally in Hull, East Riding is very rural, with clinics few and far between. The transport links are not great. And Hull, being a city centre, is very compact, just over the 28 square miles, and its transport's very good. We've got a population of about 300,000 in both, and we have a fully functioning diabetes team based in the hospital and in satellite high-risk clinics as well. We have community clinics which set up a specialist podiatry care to see those as the foot protection team and to see those patients from both cohorts. We have really good links with our nursing teams locally, where we share care readily with them and use our System 1 network to bring clarity to treatment plans and record sharing throughout our care. And we have an excellent IT infrastructure and support around that, where, like most, we upload pictures onto our electronic records, which nurses and doctors can see also, as well as we're just currently piloting a System 1 to System 1 unit referrals to just streamline the process, really, to shorten the patient time in waiting for any care. We are funded by 2 separate CCGs, with the Hull and East Riding, to mirror the difference in the demographics. So where did we start? So in Hull, we decided to go for a divided model. We now have a line that the National Wound Care Strategy has set out to what equals a foot ulcer and a leg ulcer. So anything on or above the malleoli is classed as a leg ulcer from where the ulcer originates, and a foot ulcer is anything below that malleoli. So ulcers in their first instance would go to nursing if on the leg, and on the foot would come to podiatry. And because of our already existing diabetic foot clinic based at the hospital, the National Wound Care Strategy foot ulcers were just set out really just to have that immediate access to the non-diabetic foot ulcers into the clinics. We started with our rollout last year in July. We had a very short time span to pull everything together. We really had to hit the road running. I think I was told in about April that we would be going live in July. So very little time to sort out clinic time, space, as workflow, etc. And all our clinics at the minute are staffed with a competent band 7 podiatrists to give that advanced assessment and onward referral if needed. So our patient pathway. So we accept anything on basically on the foot. We decided that we had a few previous serious incidents a couple of years ago where there'd been a delay in getting patients with foot ulcers to podiatry. So the only way we're going to get around this was when the patient was referred in, admin could then see, obviously they're not clinically trained, could book anything in, any broken skin below the malleoli into these clinics, for the fear that we could be missing something if not. And we decided later on, we would then decide if that referral pathway needed refining, if we got any inappropriate referrals. So patients can self-refer in, GPs can refer in, and anybody really, in through via ERS, email, or telephone, or face-to-face if they just wanted to, if they were passing a health centre. And admin, we designed a simple questionnaire for them to utilise, just to make sure that we weren't getting the leg ulcers where our scope of practice isn't there for the venous leg ulcers, and that the patient wasn't diabetic, and therefore that they could then go to the diabetes foot clinic. So we had everybody on board with regards to the admin teams to process that referral. It took quite a bit of training and education. This is a new way of working for people. Not everybody likes change, but we need change to improve. And it showed that actually it's made it a lot easier for everybody, because we've just tried to make it the same pathway over nursing and podiatry to mimic and mirror those throughout the way. It was a bit of a change, but as I say, it has actually come right again. So this is just a slide of our admin support template that we did on System 1, a very quick questionnaire for them to do. Are they housebound or not? Where it is, are they diabetic, is it intact, and what's happened. This is for the self-referrals, just so then we had a bit of information about where it's going, and also we could do an audit on these questionnaires to see if anything was booked in inappropriately at a later date. So where are we now with our pathway? So this is what our pathway looks like if you get a new wound, you self-refer, go through GP, minor injuries and A&E. We've had a lot of communications with different ports of call to where patients might go, like the urgent treatment centre, etc., to about referring in our referral pathway as well. So they're all seen in our first assessment clinics, where we have got access to rapid referral to vascular consultants if needed, if we suspect critical limb-threatening ischemia, or if they need admitting for IV antibiotics. We've also in the process of developing our pathways to other specialities. So at the minute we're utilising ERS to refer for non-urgents for vascular and the orthotist, but we're hoping to utilise this also to include other services such as dermatology, plastics, infectious diseases, orthopaedics, just to make that a much more seamless route for all our referrals to go through, rather than going through the GP, where there's a wait and sometimes that referral information gets diluted. We also have MDT meetings with the tissue viabilities nurses, both in the acute and community sector, and we do those remotely. And they're seen in the first assessment clinic, and then it's a bit of a one-stop shop. Everything's done in that clinic, so nothing's asked to wait to be done another time because of time restraints. And then hopefully at the end of it, we will get a healed wound. So the parameters for the National Wound Care Strategy is that everybody needs to be healed up within 12 weeks. Now, we all know that some of those, depending on patient compliance, may not be there. But yeah, so we share our care with the treatment rooms, where we'll send a plan out to the treatment room nurses to ensure that offloading is utilised with nursing and dressings, and we review the wounds as well within podiatry. So how does our clinic work? So we've currently, we have 90 minutes per appointment, but we are going to be reducing this to 60 minutes once with some band 3 to support. And as I said earlier, it's a bit of a one-stop shop. There is a lot to do. I'm sure everybody's thinking 90 minutes, wow. But there is a lot to do in this time frame with the minimum data set that the National Wound Care Strategy has set out. And at present, it does actually take that amount of time. So as I say, this one-stop shop, that everything gets done on in this first assessment clinic. So we're looking at an advanced vascular assessment, which may include femoral pulses, popliteal pulses, ABPI, TBPI. If anybody needs a slipper cast, a heel cast making, offloading in shoes, obviously your wound care, your wound mapping, consents, your therapies, outcome measures, all those things arranged, including referrals within that time frame. And the band 3 support, we've realised that we really, to utilise our time better within our department, the band 3 support is really important. So we're currently in the process of upskilling our band 3s, so then they can support in applying dressings, stripping off dressings, helping with the ABPI and note keeping. Once the patients had their initial first assessment, they are then followed up in our existing high-risk community clinic. So we've ring-fenced some appointments, so then they are there for these people to be seen, and then we will review, the band 7 will review the notes following that community appointment. So if there's any deterioration or a wound static, then that's when we would be getting back in touch with that patient, or seeing that patient again, or potentially refer them on, or discussing them in MDT to why this patient isn't on their road to healing, if it's a static wound or a deteriorating wound. And as I say, with the ERS referrals, that's made it a lot more seamless, a lot streamlined for the communication between the community and acute sector for for those referrals. And our bi-weekly multidisciplinary team, where we can have the support of the acute sector consultants to where to go next sometimes with these patients. So this is a minimum data set out by the National Wound Care Strategy. So what we need to do on top of our normal assessment, what we do as well. If you want further information about this, there's the chat link there that has been kindly put in for you. And we looked at the National Wound Care core capabilities for capabilities framework, which we're now introducing to all our competencies within our department, particularly with the upskilling of the band 3s. It's there's a lot of information on the National Wound Care Strategy site, a lot of online learning tools as well to tap into. It's a real good resource if anybody needs any direction where to go to look at those things for in future. So a few statistics here. So just bearing in mind that these are all non-diabetic patients, and we started off with only patients that could come to clinic. We have now only just recently gone out to housebound patients as well. And at present, we have the Yorkshire Ambulance Service on board. We bring in those not quite housebound patients into clinic, but struggle with mobility to get us to us, because it's important that we do. It's much easier to see them in a clinic environment, particularly with if you're casting and ABPIs, than it would be at home. So these are, I call these our early day statistics. So where we actually got our referrals from, as you'd expect, most of our referrals are from our internal podiatrists, with our community nurses also being quite up there as well. And the etiology was quite interesting, because I was expecting a lot more to be vascular referral, ischemic in nature. But actually what we saw is we had quite a lot of venous foot ulcers. So that's really opened our eyes to slightly extend our scope of practice and our knowledge base with regards to venous ulcers and obviously compression therapy. And how best to do is we've decided on a pathway now that venous ulcers, if they're on the foot, get seen with us initially, but after that, the care of those venous ulcers then goes with the tissue viability nurses and the vascular nurses, where their care is best placed for the scope of practice. Often going on to have venous ablation, depending on their comorbidities. So the communications and publicity that we've done about this, so we've got some local television, Look North, we do hot topics to spread the word to local GPs, locality meetings with other services within our area. Our weekly CCG comms goes out as well, just to remind everybody within the community and primary care where we need to do posters in GP surgeries and virtual, so quite a lot of virtual forums with the practice nurses, because it's those groups of professionals that are going to see these patients first, and we need to be getting those foot ulcers and leg ulcers through in a timely manner, rather than them not having the best care at the right time by the right clinician. So feedback we've had from patients have really liked the service, and I think part of that really is because of a bit more time spent with them, and a bit more done as well. It feels like we do have the time to actually sit and chat with them and gain actually more information about their lifestyle, and how that might actually be impacting on their wound and wound healing. But yes, it's been wonderful feedback from patients. And our internal staff, it's meant that now that they've had a good, they've got a clear pathway of what to do with those patients, and no longer struggling necessarily to get them seen back in a timely manner or seen by the right person. So it's been good. And the GPs and practice nurses are welcoming our input into the wound care and working more, as I say, more collaboratively across sectors to improve the one thing that we're all here for, and that's to improve patient care and patient outcomes. So on reflection, what would we have done differently? As I said earlier, we really had to hit the road running. So when we first opened up, we didn't see our existing foot ulcers. We're unsure how many new ulcers new referrals would be getting in. It came apparent quite early on that actually we had plenty of space to see them. So when we then rolled it out on the East Riding, it was anybody who basically had a foot ulcer already in the service was able to see as well. So the existing foot ulcers we had in the service, we definitely had the capacity to see those. So early on with the admin, we had some issues with the flowchart about referring. So we should have, the flowchart, the patient flow through the admin could have been improved on. And obviously then patients getting, as I say, getting booked in a timely manner. So that's one thing else I would have definitely done differently. And because the acute sector, our acute sector uses a different IT system, we had a hindrance of flow of information from one way to another. So we sent our information through, referral information through via ERS. But because our IT systems didn't or don't talk to each other, it's hard then for them to see what we're doing and us to see what they're doing. So for future reference, anybody, if you can get those little bits ironed out, that would be good. And I was collecting our data early on. We had very little data on how many non-diabetic foot ulcers we had actually in our caseload, how many we referred in, just of basically how we recorded that data. We've had a massive change in our System 1 templates to encompass the new minimum data set from the National Wound Care Strategy. And within that, those new templates, we've got the read codes as well, so we can pull out that business intelligence, which has now led us to actually gain some more funding from the National Wound Care Strategy to fund some more staffs and more clinic spaces, basically, so we can see these patients, because it's actually flagged up that we don't have enough to see everybody. So collecting the data early on is quite key to what we needed to do. So yeah, so the recommendation, start collecting your data as early as you can. If any service managers out there, do start collecting your data on your foot ulcers as soon as you can, using potentially a SIMBAD scoring system, the duration of them, etc. And another thing will be upskilling your workforce. So although we have a good cohort of podiatrists on a band 5, band 6 and band 7 level, we feel that actually a lot of our podiatrists, we could do more. And we need to see those patients who are more at risk. So the more of us that can do ABPIs and wound care, the better really for us. Electronic record keeping, yes, if you're going to be doing any alterations within your System 1 unit or whichever electronic record keeping you use, bear in mind the minimum data set for those and maybe include that with there. And your key relationships is really important to foster those good relationships between the acute sector and also your community nursing teams. who might help. And obviously think about your budget, about if you've got any extra money left over, do you need to be buying some toe brake or pressure equipment, or using that for training, basically. And from that, as I say, our business intelligence has meant that we are now in a position where we have funding for 2 new Band 6 podiatrists, which is a development role, working towards a Band 7 post. So we're looking for an experienced podiatrist to take the next step with the support in place, working mainly around the national wound care strategy in wound care, offloading, lots of cross-discipline and multidisciplinary team working. So come and join our team in the glorious East Riding of Yorkshire and Hull. We're a friendly team, but if you want any other information, then please contact our operations manager, Donna Welsh, and details are there below. Any questions?
That was great. Thank you very much, Ruth. There are a couple of questions in the Q&A chat for you. Well, the first question is from H. Hill. Did you have enough Band 7 wound care specialist, diabetes specialists to cover everything?
So when we originally kicked off, yes, we did. We had a bit of a restructure about 3 years ago, which was quite helpful, actually. So yes, we did just have enough to have the skill set there to be able to carry that out. But obviously, everybody's staffing structure is slightly different. But yes, we did have enough. But we need more. We need more, basically. And they don't grow on trees, so we'll have to figure it out somehow.
Absolutely. Workforce is another question, isn't it? Yeah. And then Laura Saunders asks, just wondered how you managed to set up bi-weekly virtual MDT meetings for non-diabetics. This is something we really want to do, but are struggling to get our acute colleagues to do this. So the bid was put in jointly with Vascular, so to be one of the pilot sites. So obviously that we've got our Vascular on board, really. So that's basically where it's come from. We felt that we needed that input from the community to keep those relationships going, and to iron out any problems also with pathways we were having. So not only do we discuss patients within that MDT, but if we've got any issues regarding pathways and referring in and those sort of things, we discuss those as well. But there are obviously a great wealth of knowledge, and every MDT, I think we all learn a little bit more, don't we? Yeah. A question from me, really about commissioning. I know that there are a lot of secondary care centres that will take people without diabetes simply because there isn't anywhere else to go. But very often there's difficulty repatriating those patients back to community settings. And I'm just wondering how that commissioning process worked, or where the funding has come from to enable that. So one of the arguments was that we were commissioned to see non-diabetic patients anyway. Was that we were commissioned to see these patients regardless. We're now just seeing them in a different way. Yes, we're now seeing them sooner, and because of the new referral pathways with the line in the sand on the malleoli, we've got more foot ulcers coming our way, but I think that's the way it should be. You know, we've got a different skill set to nursing, and we need to be proud of that, and to actually, you know, use those skills to help to improve those patient outcomes. Yeah. So commissioning, obviously this is the pilot for 2 years, but once this blueprint's been set throughout the country with the other sites as well, that information will then go towards building new guidelines for that commissioners will have to prick their ears up for. Yeah, I was going to ask you the way forward, because I think we need some more guidance, and we need some commissioning guidance as well, because it can be quite delineated as to who can access which areas of service. And of course, stamping out variation is one of the big watchwords in the NHS at the moment. So that's, we will watch your space very carefully to see how that develops.
Lovely, thank you.
Ruth, thank you very much.
Thank you.
So we move on to the next speaker. And the next speaker is Kate Boozy. Kate's a chartered counselling psychologist who's been working within the diabetic foot team at St George's Hospital in London for 3 years. Kate established a psychology provision from scratch, setting up a diabetic distress screening programme to support those with complex mental and physical health issues. Along with providing support and treatment for inpatients and outpatients, Kate also advises the team through training and consultation. Kate, who has more than 20 years' experience working as a counselling psychologist for people with long-term health conditions, says that the podiatry clinic is now a more psychologically informed service, and that those accessing the clinic benefit from a holistic model of care. As well as treating people with diabetes distress, anxiety, and low mood, Kate also helps to mentally prepare those who require an amputation. Kate introduced diabetes distress screening procedures into the diabetic foot clinic as part of her role as a Diabetes UK clinical champion. She is now one of a handful of psychologists working within diabetic foot teams, something she would like to see rolled out across the country. Hopefully we've got Kate online there somewhere. I think you're unmuted.
Know me, but if you don't, I'm a counselling psychologist and Diabetes UK clinical champion working at St George's Hospital in London. I've been working in the foot clinic for the last 3 years, where I set up psychology provision. This presentation is relevant to all healthcare professionals working with diabetic foot because it shows the interaction between a person's mental health and their diabetes, and why it is important to recognise distress at an early stage to prevent complications. I'm going to just show you my slides, and I want to talk about my aims first of all. So I'm going to talk about a psychologist's role and why a diabetic foot team should incorporate psychology into their clinic. Then I'm going to look in more detail at my role in the foot clinic, and then talk about psychological issues, the type of psychological issues I might see, and then flag up issues related to health inequalities, deprivation and engagement. And I'm going to finish off by providing some resources for non-psychologists. So what is the role of a psychologist? What does a psychologist do? So a psychologist's role is to assess and provide evidence-based intervention for people who are experiencing mental health problems, emotional distress, behavioural issues or physical health problems such as diabetes that impact on psychological well-being. A psychologist will also develop understanding with their patient and the teams, or in psychological speak, formulation, based on the interrelationship between a person's thoughts, how they feel, how they behave, their social relationships, and their illness, which in this case is diabetes. So the aims of treatment is to help patients to come to terms with or adjust to diabetic foot complications. So, you know, a patient might struggle with wearing a cast, or there may be a life event such as amputation, which is unfortunately all too common. So the aims of treatment is also to help a patient improve adherence to treatment, help them to comply with what they're being told to do. So the aim is also to help reduce distress. So that might be to help a patient manage depression or anxiety, to help improve their self-management. Additionally, the psychologist aims to assist patients to make lifestyle changes to support good self-management and also to address any barriers to accessing care. Training, supervision and consultation to support wider multidisciplinary team working and maintain a psychologically informed service is also part of the psychologist's role. So why are psychologists needed in the foot clinic? Well, we know that diabetic foot problems are costly, and we know that outcomes are hugely variable due to behavioural and psychological issues. We also know there's a lot of risk in the diabetic foot clinic, that's medical risk, and from my point of view, psychological risk. So the psychologist aims to minimise harm and complications. The psychologist also helps a patient and their teams to understand motivation, engagement, and issues around consent. The psychologist also supports the MDT decisions and patient advocacy and provides a reflective space for the team where cases can be discussed. So what happens if we neglect the emotional and psychological needs of our patients? Well, evidence shows a link between long-term physical health conditions, including diabetes and depression, and we know that depression can impact on self-care, including diabetes self-management. So diabetic complications resulting from non-compliance can lead to increased healthcare costs, poorer outcomes, length of stay, hospital stay, increased length of hospital stay, increased outpatient visits, poorer quality of life, greater disability, and increased admissions. And if anybody would like that evidence, please email me and I will let you know where that comes from. So psychologists can help their patients and their diabetic foot teams to manage depression and increase motivation to self-manage and engage better with their services and treatment. So the statistics show us that depression affects 10 to 20% of people with diabetes. And we also know that depression may predict poor ulcer healing. Now, there's some references there, but again, I'm happy to send them across if anybody would like them. So something about my role at St George's Hospital. Well, I suppose my aim is to improve the well-being of diabetic foot patients and help them improve their self-management. So my aims include building a psychologically informed service where holistic and individual care is provided by all members of the team and distress is picked up quickly. I am an integral part of the team who refer to me, and I run inpatient and outpatient clinics. I also support the team through joint working, training, and offering consultation and advice. My work is also sometimes with relatives who find it very distressing, particularly if somebody is going through amputation. So I'll work very closely with relatives too. As well as helping patients to manage depression and anxiety, I also support patients to make informed decisions about their surgery. I am a key part of the pre-amputation pathway, so all patients going through amputation will have contact with me. So who are our clients and why are there such high rates of distress in the diabetic foot clinic? I want to talk for a minute about adverse child events. Now, the evidence shows that the greater the number of adverse childhood events, the more likely a person is to develop chronic health conditions and risky behaviours later on in life. These often lead to negative outcomes such as reduced educational, occupational achievement, heart disease, obesity, depression, substance misuse, and even suicide. A lot of the patients I've worked with have been brought up in care and experienced high levels of neglect and abuse. They often have enduring and serious mental illness, such as long-standing depression, personality disorders, learning difficulties, substance abuse, and cognitive decline. Comorbidities are also distressing, such as sight loss or a patient who's receiving dialysis. So I want to talk now about the diabetic foot and the clients. And we know that diabetes is a bit like having a full-time job, except there's no breaks in the evenings, at weekends, on holidays, or when you're ill. So the patient needs to remember to take medication, test blood sugars, eat a healthy diet, and attend medical appointments. Diabetic foot disease amplifies demands. So there's more healthcare professionals to see. The patient cannot feel their feet but needs to check them. They may be weighed down with burdensome treatments such as casts and bandages. They might struggle with reduced mobility, making it difficult to exercise. They may have had bad news in the foot clinic about amputation or be living with uncertainty about what might happen. And they may feel shame or guilt about having not managed diabetes sooner and the burden and upset they've placed on their loved ones. So it's quite a difficult, diabetes is a very difficult disease, and it's particularly difficult for diabetic foot patients. So coming back to the role of a psychologist is very interested in the importance of patients' beliefs. So that, psychologists want to know, what does somebody think? What do they believe? What's happening with their behaviour? So beliefs around non-compliance are really important. Does the patient understand what they're being told to do? Or do they believe that foot complications happen to others and not to them? Once beliefs are understood, psychological intervention will be tailored to the patient. The aim, of course, is to try and avoid amputation. So what type of diabetic complications do I work with? So I've already said I'm a key member of the pre-amputation pathway, but I also support patients who are struggling with Charcot foot and casts or healing of ulcers. I help patients to cope with life events such as amputation or burdensome treatments such as casts and bandages, and help patients manage depression and anxiety to support their self-management. So the pre-amputation pathway, I've kind of raised it several times, and I want to talk a little bit more about it in detail. So if we're able to, if there's elective surgery or there's time, I will often be involved in joint working, joint assessments, and think with the team about how would this patient cope with amputation. Do they understand how will they cope after surgery? Do they have support from friends and family? Is there a previous mental health diagnosis? Are there any current body image issues? Are there any intimacy issues? I'll want to help to prepare the clients for surgery, and I'll want to normalise the patient's fears and grief and introduce them to support groups if I can, and then help once they're in the ward, work on acceptance and building compassion. So I've sort of talked a little bit about my role on the pre-amputation pathway, and I often see patients on the ward awaiting amputation. Sometimes I'm not sure if they completely understand, so we look at the benefits and the risks together. We look at capacity, are they able to make the decision? We look at their expectations. What are their hopes? What are their dreams? What are their fears? Have they had any previous experience, or do they know anybody else who's undergone, for example, an amputation? Are they able to manage their post-surgical care? Do they have people around them? What are their coping strategies? And, are there any other social stressors such as housing or benefits, for example? So we need to think that, if somebody has an amputation, an amputation affects all aspects of someone's life. It affects their relationships, their careers and dreams. It's really a loss of part of themselves. So just to kind of talk a little bit more about kind of issues that I see when I work with amputees, is there's very often, loss and adjustment will be part of the treatment plan. How is somebody going to adjust to losing a limb? Trauma, is there any underlying trauma? Sometimes trauma can come up in amputation. Is there any previous depression, anxiety? Does the patient have, perfectionist tendencies or unrelenting standards? How's that going to interact with their procedure? Are they, is there self-neglect? Are they avoidant? Might they sabotage rehab? We've talked about role change and how somebody's role will change, and also the family and the carers. How are they coping? The patient also might be uncertain about whether they can have a prosthetic, and they might, have like really difficult feelings such as shame, fear, frustration, sadness, failure, and isolation. So are we missing anything? Sometimes when I am at a patient's bedside, I ask myself this question, and I think to myself, could this have been prevented earlier in the pathway? has this patient engaged with the services they need to? I, of course, don't have any answers, only to think about the things I'm told by patients. And very often I sort of see quite a lot of kind of, deprivation there, quite a lot of kind of health inequalities, if you like, that have been worsened by COVID. But really, I can only highlight the typical characteristics of the patients I see. So my question is, why is it difficult for this population to engage? So we see mainly older, mainly single males, very often manual workers, chefs, security guards, cleaners, very often low economic status, patients with unhealthy lifestyle choices, poor glycemic control, obesity, diabetes-related complications, and poor adherence. Very often there's poor educational attainment, some patients with learning difficulties, very often financial poverty, there might be no or limited sick pay, so a patient may be told not to stand on their diabetic foot, but they haven't got any choice because they haven't got any sick pay or any other means to support themselves and their family. Our patients also have a high degree of digital poverty, and as we know, diabetes services are going increasingly online, as engagement is very often an issue with this group, that might be incredibly difficult for them. So these patients often have difficulties engaging with medical or mental health services. They might not attend their foot checks. They might not be able to engage in mental health services, for example, with opt-in procedures such as IAP. And as we know, this has all been worsened by COVID and by long waiting lists. There might be high levels of medical non-adherence going on. There might be social stresses such as housing and benefits. And, of course, we know about the postcode lottery and some patients who might have luckier services than others. So why is it so difficult for this patient group to engage? Is it a lack of know-how? Is it struggling with opt-in procedures? So I've talked about IAPT and having to sort of engage and call, wait for the person to call and go through questionnaires, which is sometimes difficult for these patients. Are patients falling through the gaps? So, the patients may be too complex for some mental health services, such as IAPT, and not risky enough for others, such as the community mental health team, who will discharge them quite quickly. So we also know about the mind-body split, the lack of communication between medical and mental health services. There's different systems at play. Sometimes they don't talk to each other. And medical appointments, we know that diabetic patients sometimes struggle to get a GP appointment, and it's very often see the healthcare professional twice, so difficult to build a relationship with the same practitioner. So what else is missing? Now, we know that the policy and guidance tells us, the Too Often Missing report from Diabetes UK, that emotional and psychological support must be an integrative part of all diabetes care, and that, diabetic patients need greater access to specialist diabetic mental health support. And we know that the NICE guidelines highlight the importance of developing integrative care approaches and routine screening to improve the identification of mental disorders in chronic illness. However, the adaptive pyramid of needs shows us that whilst level 2 is served by IAPT, so mild to moderate depression and anxiety, which IAPT are great for, and whilst level 5 is served by the kind of community mental health team and, the home treatment team, there are, there's a gap for diabetic patients at level 3 and 4. So, the gap would be really any kind of psychological problems related to diabetes or difficulty coping because of complex issues. So severe and long-standing depression, anxiety, trauma, social difficulties, substance abuse. For example, where does a 65-year-old man with long-standing depression, trauma, a difficult child and poor self-management go to? So this adaptive pyramid of need and the gap at levels 3 and 4 shows the gap between mental and physical health. So mental health teams often have limited knowledge of diabetes, and diabetes teams often don't have access to psychologists. So there needs to be greater access to specialist diabetics. There needs to be greater access to specialist diabetic psychologists and, you know, more upskilling in mental health issues for diabetes professionals. Just to move on to tips for non-psychologists, and thinking about how to pick up distress in your clinic. So you might want to think about putting together a business case for getting a psychologist in your team. And you might want to think about screening. So screening picks up distress sooner and helps get a wellbeing conversation on the table. You might want to attend relevant training on mental health. So Diabetes UK have got a lot of information on mental health, both for clinicians and for patients. And also Spotlight AQ offers a lot of training for health professionals working with diabetes. Non-psychologists can also offer brief interventions supported by good training, resources, support, supervision, or reflective practice, as long as their patient is not at risk of harm to themselves or to others. Now, I want to talk just for a minute about delivering bad news, and I want to draw your attention to the Language Matters document that everyone is familiar with. So just thinking about the language we use in diabetes appointments is really important, and the wrong words or a rushed consultation can leave patients feeling that they have failed. So we need to think carefully about our choice of words, particularly as the relationship between the healthcare provider and patient is key to successful self-management. So recommendations would be to find a private space, be kind to your patient with a chance to ask questions later on, write down any options the patient may be too stressed to remember, and ask them whether they want family or others to listen in, and also to give support numbers to them as well. So language does matter, and you know, it's really important to use everyday language and avoid jargon, to ask one question at a time, to avoid asking leading questions, to allow time for your patient to answer, and to give and seek feedback regularly to clarify understanding. So I want to finish off just by talking about signposting. And obviously, if you pick up diabetic distress or patients with a history of depression or anxiety, then it would be important to refer to your diabetes psychologist if you have one. I've talked about IACT, and IACT is great for mild to moderate anxiety. It's also a free mental health service, and it may be able to direct your patient to, for example, the community mental health team if the patient has any kind of risk issues going on, like thoughts of self-harm. The expert patient program is also a good source of support for diabetic patients. It's a source of peer support, and it's run by an expert patient. You can find that online. And self-help reading is really important. I know that Imparts at King's College have produced a lot of self-help reading, which is really, really useful for patients. Just to finish off by flagging up some useful resources for healthcare professionals, I'll be sending this to you, so you'll have this to be able to have a look at, and some useful resources for patients. So some of the resources are Diabetes UK, which are great, and others are like internet resources, and there's some useful apps like Headspace and Calm. Just to summarise, and before I finish, psychological support should be in place for all stages of the diabetic pathway, and specifically at levels 3 and 4 to support self-management and reduce diabetic complications. Patients attending a diabetic foot service may be complex and often struggle to engage with services. Psychological issues are one of the main preventable causes of distress and early progression to complications in diabetes, which are generally missed. Screening helps to pick up diabetic distress sooner, but relies on a team believing that inquiring about well-being is in a patient's best interest. If it is, a brief 2-item screen like the DDS Diabetic Distress Scale is quick and easy to administer. If you have any questions, please contact me on this email address at St George's Hospital. And I want to thank you very much for your time in listening to me today, and to take any questions you might have. Thank you.
Thank you very much, Kate. Wow, there's an awful lot that I think our patients don't get. They miss a lot. Where do you think would be a good place really for patients to start? Do you think this is something that should be happening in primary care more, or do you think actually we need more psychological support across the board?
So, I mean, what you're really talking about is the pathway, isn't it? The diabetic pathway. And I mean, basically, there should be psychological support across the pathway. So, you know, looking at that pyramid of need, it's levels 3 and 4 which are missing kind of at a higher level. So we know that in primary care we've got IAPT, and there's some diabetic provision there, but we know it's from mild to moderate sort of depression and anxiety. But it's kind of the acute services really, and the MDTs, which need a psychologist as part of the team, and that's where the gap is. So the Too Often Missing report talked a lot about patients' experience of feeling that their emotional and psychological needs are not being taken into account, and also the healthcare professionals also felt there needed to be a psychologist in the team. So it is level 3 and 4. You see, the problem is as well is the kind of the gap between mental health services and kind of medical services is in a way, they're maybe not talking to each other as much as they want, and the mental health services haven't got the experience of diabetes, and the diabetic teams, obviously they're busy with diabetic footwork and don't necessarily have the skills and the knowledge to kind of, and the time to look at the mental health issues. So there's these sort of howling gaps going on at levels 3 and 4 basically. And the other problem is when the patient gets to level 5, which is the community mental health team, they get discharged very quickly if they're not at risk. So if they haven't got a bottle of pills in front of them, they're likely to get discharged. And if they're too complex for IAPT, they're likely to get discharged there. So, this is really the gap. And there needs to be psychology provision and specialist psychology provision across the whole diabetic pathway.
Okay. Lawrence Ambrose asks, other than St George's and King's College Hospital, are you aware of which other or how many other multidisciplinary foot teams have psychological support?
So in terms of working as a part of the MDT, it would be, I think Surrey has recently got somebody, I think there's 2 psychologists over in Surrey, but they're on very limited contracts, but they're quite new. So that's good, but apart from that, I don't know of anybody else that's there.
Somebody's asked, hi Catherine, how can I contact you to discuss further the needs of psychological support for patients with diabetic foot disease?
So my email that's on the slides.
That's fine. What we could do is possibly pop your email address into the chat box, which would be helpful, I think. So at the moment, and also David Garcia has very kindly put the pyramid in the link to it because he said it was a little bit blurry online.
Thank you.
which would be really helpful. And I think one last question, whether you think that there is a way to bridge that gap for the level 3 and 4 groups?
I mean, I think bridging the gap would be to get a psychologist into the MDT, the various MDTs.
Yeah, do you think that might be something that's achievable through integrated care services?
Yes, I mean, that's how the post I got was basically set up as a pilot, and then I basically kind of put together a business case with my manager, and we managed to get permanent funding for the post, but it was set up as a pilot. Absolutely. Yeah,
fantastic. And maybe some of those resources, what we will do is put them onto the English Diabetes Foot Care Network website, and just give people ease of access to all of that as well.
Right.
Okay, thank you ever so much. That's been fascinating.
Okay, thank you very much.
Thank you very much. And so now we're going to have a short comfort break, and we will be back online with you at 2:20. So 2:20, we'll see you then. Hello everybody, and welcome back. We are now moving on to the second part, in which David Thorne is going to talk about ICS changes and the potential impact on pathways of care for patients with foot ulcers. David is a director of NHS Insight and Interaction at MedTech Access Limited and development director at Well Up North Primary Care Network. The session is designed to help delegates understand the current integrated care changes to the NHS and their implications for foot ulcer care, understand the new financial flows and performance metrics that should enhance successful cases for change to drive service improvement and investments to foot care, and identify practical opportunities for developing improved foot ulcer care. Thank you very much, David.
Thanks very much, and thanks everybody. I'll share my screen. Yeah. I'll move over there. Okay, thank you. I'm a former psychiatric nurse, so I was listening to the last speaker with a lot of interest, and I'm extremely conscious of the fact that as an audience, you'd be very interested in the clinical aspects of diabetes and foot care, and not necessarily the things I'm going to present about, especially on a Friday afternoon before a bank holiday. So stay with me. I promise there will be parts of this that are hopefully really relevant for your roles. And thanks, Richard, for introducing me. So I'm going to try and stay away from acronyms and managerial speak, but this is basically what we're talking about. The NHS is going through extraordinary changes at the moment. You can see how old I am from the screen. I've been through multiple NHS changes. I'm sure many of you have. And often they're superficial. This is really, really important. But perhaps because of COVID and other things going on to do with events, sad events elsewhere in the world, there's not a lot of attention on what's going on. So these are the most important changes that I have seen in the NHS that are least understood by clinicians. Okay, so what's happening is this. The idea is we will build an integrated NHS local family, right? Most people, I can't see you, but you will be younger than me. The NHS that you've worked in has been one of competition, where trusts are in competition with each other, GP practices are in competition with each other. This has changed. So what we now have is teamwork, local managed systems with a single pot of money. So that means the internal market, as we used to call it, competition, the payment mechanisms like payment by results, where when patients used to go into hospital, essentially a financial fee used to follow them. All these systems are gone. Those ways of working are going. Hospitals are consolidating into larger groups, and primary care is consolidating too. Just to that last point, Richard mentioned I'm a director of a primary care network. I'm speaking to you from the north of Northumberland. I'm only about 10 miles away from the Scottish border. And we have 12 practices in, sorry, Catherine, you got your hand up? Is that, oh, sorry. Just going back to our practices, we have 12 practices, 80,000 patients. Essentially, we're one, effectively, to all intents and purposes, we're a giant GP practice. When I was younger, probably when I was about 40, there were 10,500 GP practices in England. There are now something like 7,000, even though the population has grown. So the magic words from this are integration, consolidation, teamwork, partnership. So it's a very different NHS, unless that is you work in the NHS in Wales or Scotland, where they've essentially had these kind of systems all the time and haven't had the competitive arrangements. Again, before I bore you too much with management speak, this is really important for you as a group. Population health management. This is a policy that underpins everything that is going on at the moment. Now, why that is crucial is what many people have sometimes had is, and it is outdated, but a kind of medical model of looking at heart failure or COPD. Whereas I think most of us who are clinicians, most people, we see middle-aged man, like our last speaker talked about that kind of example, young mum, elderly person who lives alone. We think of concomitant conditions and types of situations that affect patients. The new policies are all based around population health management. So this is really important for diabetes. I think it's a great opportunity for you, like the last speaker, about connecting to mental health, about seeing the holistic position of patients. And of course, that's so crucial to the area that you work in. So if you are about to fall asleep, this is the takeaway message for you. We are going through the most significant change to the English NHS for 30 years. And it is happening behind the scenes. I wonder how many of you, there's over 100 of you listening at the moment, yesterday, the legislation that is driving this was given royal assent by the Queen. So that means it's happening, okay? Let alone the detail, the NHS is making major, major changes, and all of this is happening. It's gone through Parliament, so it's gone through the House of Lords, it's had royal assent from the Queen, it is happening. So the NHS is moving to this structure. In many of the areas that you work in at the moment, they've really worked fast to go over to these structures already. So we've got NHS England with 7 regions. I'm going to show you in a map in a minute of 42 integrated care systems, each one of them run by an integrated care board. Then out in primary care, we've got 8,000 GP practices, now in 1,250 primary care networks. So as I said before, I work with 12 practices in the far north of England, and we're part of a primary care network. Increasingly, those of you who work in secondary care will be part of provider collaboratives. And many of you will be saying, we need to write a business case, or they've changed the way of working from place. So these are confusing new terms that I apologize in a way that I'm throwing at you, and I'll go through in turn, but I'll have to do it quickly, otherwise I'll destroy your whole event. So England is now divided into 42 areas, 42 integrated care systems, and they are very different. They're different financially, they're different in size, they're different in terms of the priorities that they have. They are predicated on difference. That is one of the points. The term postcode prescribed been used before, or postcode lottery rather. And we're going to see increasing variation. So I live in the Northeast, right at the top there, the Cumbrian Northeast Integrated Care System. We will have different priorities from inner city London. We'll have different priorities from Norfolk, from Devon. Devon will have priorities based around seaside towns, Plymouth, and an elderly population. Our ICS is a combination of post-industrial areas like Newcastle and Sunderland going through big transitions, and rural areas like the one that I live in. They're different in populations. My integrated care system is 3.2 million. If you go to Gloucestershire there, number 34, I'll probably mention them later, they've got a population of 600,000. So what matters to you as a clinician, the first challenge I would have to you is, so which one do you live in? So the one that I live in is based around that. We're the largest, 3.2 million population. We're divided into 13 places. I'll describe those in a minute. And then we go down to 74 neighborhoods that are coterminous with the primary care networks. So we have this new geographical way of seeing the world, a sensible taxonomy that typically is 50 to 60,000 people living in a neighborhood, going up to 250,000, 300,000, something like that, who live in a place, and then going up to a system that is typically 1 to 3 million. So that's the kind of way that health services will be constructed and planned and delivered from now on. I mentioned there about place. It's a really unfortunate term. If you think of your upper tier local authority, the local council that runs the schools local to you, there's 150 of those in England. They usually have populations around 250 to 500,000 and expect places to be that kind of size. So as I said, there are 13 in my ICS. If you're in West Yorkshire, there are 5. If you're in Cheshire and Merseyside, again, there's around about a dozen, depends where you are. Formularies and guidelines will increasingly be set at place, which will be important for you, your prescribing, and the kind of clinical areas that you do. The money is held at the Integrated Care Board, given to the places, and then can be pulled back. So the organisations that you work in on your payslip, could be a foundation trust, community services trust, or whatever, they don't necessarily have their own budgets anymore. The ICB has the budget and it devolves the money to them. As I said before, it's a little bit confusing, but each place is broken up into neighbourhoods that are usually coterminous with the primary care networks, so they make sense to local practices. So if you haven't got the message yet, this is the point. There are new people, priorities, attitudes, new ways of working. And I put a little photo up there of a friend of mine that is the job that he is now doing. So he is the place managing director for East Cheshire. So again, predicated on difference. What Mark will be doing, and all the colleagues who work with him, they'll be working on things that matter for East Cheshire, for the population, its demographics, its epidemiology. Something else we get used to, is Mark a commissioner? Is he a provider? He's neither, he's both. Okay, the NHS has broken off from that commissioner-provider split and moved over to one integrated team. And just to show some variation, is another person I'm friendly with, Jack. So Jack, they all have different titles. He's the place lead in Northwest Surrey. So if you know the London area, the kind of, I'm just trying to think of the towns. Woking, I think, is one of the towns that's in Jack's place. And he's got a population of 470,000. It's quite a big place. So again, Jack and his colleagues will be coming up with different systems, different ways of working, different formularies, different guidelines, different approaches that make sense to Woking. And then you've got my friend Mark, he'll be doing ones for places like Crewe in Cheshire. What they will all be doing, I promise you, is focusing on things that matter to you. So diabetes clearly, but let's look at the population health thing and trying to avoid the clinical label. Risk, frailty, the concomitant conditions, all the things around mobility. So it doesn't matter whether you're in a city, whether you're rural, north, south, whatever, people are focused on your kind of patient. Now I mentioned that we've got this clear taxonomy, you've got this hierarchy of system, place, neighborhood. But there's some spice thrown into the mix here, and that's the provider collaboratives. This is a very different way of working. If you were employed by an acute or mental health NHS trust or foundation trust, your organization has either joined a provider collaborative or is going to. If you're wondering what they are, I've got the link on there, and it takes you through to a slide deck. That's the cover of it there. And it explains what the provider collaboratives are. Community trust, because many of you will work in those, they can join provider collaboratives, but aren't mandated to do so. So can NHS, non-NHS providers. So let's say a hospice could join. An organisation potentially, a local Diabetes UK organisation could potentially join. And your organisations can be in multiple collaboratives. So you could have a big trust. They could be one collaborative for gynae. They could be in another collaborative for diabetes and heart disease. The collaboratives can cross ICS boundaries, and trust can be commissioners. So I said this is very, very different now. We don't go through the same procurement hoops. The money goes around the system differently. It's all about teamwork and people working together. So one of the challenges I throw to you, and maybe some of you are ahead of me, when you read that provider collaborative set of slides, there is nothing to stop you as a group of professionals looking to set up a foot health collaborative. You could set up a West of England Foot Health Collaborative, or a West Midlands Diabetes Collaborative. That possibility is there now. But one of the first things I'd ask you to do, apart from finding out which ICS you're in, once you find out which ICS you're in, is then say, so the local trusts, which provider collaboratives are they joining and why? And where are my clinical specialisms? I mentioned before that the money flows around in a different way. For many years, let's imagine I'm not diabetic, but imagine I was. And I might go and see my GP, go to A&E, ring an ambulance, I've got a hypo, get admitted to hospital, hopefully not, but I might even have my foot amputated, but I might have social prescribing, I might have community follow-up. In the past, every time that happened, there was this episodic transaction through payment by results or another mechanism. All of that is gone. So during the COVID era, we moved to block payments. They are likely to continue for at least the first quarter of this year and probably longer. However, where you ought to get excited as a profession and as a community of practice that's obviously got a shared interest here, is what we're heading for is something called the Aligned Payment Incentive System. Now, the documents I've got on screen there, these are very complicated documents. But if you talk to business managers, you talk to service managers, finance people who are colleagues, they'll explain this to you. The APs, as we'll get to call them, Aligned Payment Incentives, they're a bundle of care, they're a blended payment. So let's go back to me being, say, a typical middle-aged man who's a type 2 diabetic, maybe got heart disease as well. All the things I talked about before, every one of those episodes of spells of care, they can be wrapped up now. So you could have a Liverpool diabetes contract, or a South Yorkshire long-term conditions arrangement. So we can bring things together holistically. I think this is a great opportunity for stimulating imagination in foot care. Many of you will be thinking about business cases you've done before, or you try to change services, and people have come back to you and said, but that's not my budget. Or if we do that, that benefits the ambulance trust and it doesn't benefit us, or the GPs will get the benefit, not the hospital, or vice versa. We had all these perverse incentives. What you're now saying is Mr. Thorne's type 2 diabetic. It costs the NHS overall £15,000 to look after him over the year for everything. His wound care, his medicines, seeing his practice nurse, going into hospital, whatever. We can wrap that up in one arrangement now and say, what can we do better for that £15,000? What works better? Health economists call this program budgeting. That's the methodology we're going to. And it really is exciting. And one of the things that really makes that exciting is for the last 25 years, we've had systems that perversely have encouraged hospitals to bring in activity. It's rewarded hospitals financially for bringing patients in. Without getting into the complicated details, the new systems reward hospitals for diverting activity. And this is happening already and has been hastened by COVID. Right at the start, it said, I'm a director in a PCN, a primary care network, and there's, as I said, 1,250 of those. It's all about at-scale working and teamwork across primary care. There are all kinds of people coming out in PCNs. Many of you will know about this, but if you don't, immerse yourself in it, because when you're a PCN, you have ring-fence money that comes from NHS England. It's quite generous money. And we can choose to appoint people from those 14 roles. Now, if you go down those, and I particularly enjoyed Catherine's presentation before, because it made me think, if you go, in my PCN, we have 8 clinical pharmacists, many of them prescribe. We've got 8 social prescribing link workers. Now, some of the issues that Catherine was describing, particularly the lower level support to patients, in practice, that's going to come from social prescribing link workers. We also have 8 health and well-being coaches. I've got a friend who's a practice nurse in Watford, and she's got a team of dietitians in her primary care network. But it's hard to think of any of those 14 roles that wouldn't come in contact with your kind of patients. And when a patient says, I've got a problem with my feet, I've got a problem, or they take their shoes off, or they're curious, their carer says something about a foot ulcer, this is the point of entry. This is where those things are going to be found out. Again, I don't want to bore you with all the details of it, but if you look at that document I've got on there, all the PCNs in the country follow the same directed enhanced service. So there's a kind of national way of them being funded and rewarded. And believe me, it directs attention to the same things: frailty, mobility, diabetes, high intensity users, care homes, older people, exactly your kind of patients. So I just want to come to the end in summary of me as an outsider, if you like. So, you know, feel free to disagree and ignore my advice. But frailty, how many times have I mentioned that today? That is so important. And the pandemic has taught us so much about it. Every practice in England now has an electronic frailty index. Foot care is really important in that. I just mentioned some of the other things. I talked about population health management. We've got the money going towards the APs. Wound care and prescribing, I think, is an area that is going to be under attention for the next 2 years, whereas perhaps it hasn't been recently. And we have virtual wards. Again, most of you will know about virtual wards. This is so important now. Right across the NHS in England, the chief execs of all the organisations have been driven to get ambitious roadmaps and targets that they have to achieve, their performance managed on it. I think the virtual wards are really going to drive thinking around foot care. Because people are going to see, at last perhaps, you would say, how important foot care is in that Venn diagram of care. Yeah, when somebody gets admitted, and in the old days we say, oh, they got admitted because they were respiratory, or admitted because of this, or admitted because of that. And what you know is they were admitted because their daughter went away and somebody neglected to look after them, or their mobility went, or a dressing wasn't done properly, or the wrong kind of dressing was applied. It's really important, things like that. Extremely important day-to-day things. I'm just going to explain finally this point about value-based healthcare and AP. As I was saying before, that I could add many more to this, but let's look left, right. All my little pictures there that I'm taking off Google Images, yeah, that shows the kind of thing that your kind of patient would go through during the year. And we could have put a lot more pictures in, couldn't we? And all of those used to be in isolation, run by different organizations, different IT systems, fragmented, and crucially, completely separate financially in terms of the funding. What we now have through integration and some of the systems that I've mentioned is the ability to look at the holistic patient and the patient pathway. Okay, so I'll stop boring you with my slides there. And Richard, thank you very much for your patience and again for inviting me.
David, thank you very much. I think that has made things a lot clearer than they were certainly in my head. Not really understanding, because my world is secondary care mostly, so not really understanding how all this integration was going to work. I suppose one question is given that the Royal Assent went through yesterday, how long will it be before this is completed, and how do we get involved to make sure that diabetes and foot care is managed properly and is a properly integrated service?
Right, great question. So the first one's a factual one. The current aim is that it will all go live on the 1st of July. So at midnight on the 30th of June, CCGs will be abolished. You see, I didn't mention them. And ICBs will become the statutory body. So the 1st of July is the current target date. It was supposed to be the 1st of April, and it was put back because of COVID, Ukraine, and to be blunt, probably things to do with Boris Johnson and Partygate and things going on at Parliament. So 1st of July, but in most areas of the country, we're ahead of that. Where I am in the far north, we're essentially working in that way already. So coming back to your diabetes thing, I said I'd mention Gloucester, and your questions allow me to do that. Gloucester is a really good integrated care system, and they've got 14 program groups that have been running for a couple of years now. So there'll be ones on mental health, diabetes and long-term conditions, heart disease, orthopedics, whatever. In most, I nearly said everywhere, in most integrated care systems, there's extensive work going on already. So if you don't know about it, reach out to colleagues who might be on things like strategic clinical networks, if they're clinical directors, if they work for the chief nurse in a hospital and they might be involved in lots of working groups. Find out where they are, because it would be extremely unusual that that work hasn't been happening. And so instead of thinking, crikey, how do we start this off? It's a little bit more like, crikey, how do we make sure we know what's been happening anyway? Okay.
Yeah, that's great. And I think there's one question. Oh, don't know what I've just done there. Okay, I'll come back to that. Lovely. Thank you, David, very much. As I say, open my eyes. So that's been really helpful.
Thank you, Richard. That's very kind of you. Good luck, everyone. Enjoy your conference. It sounds a great agenda.
Thank you.
Thank you.
I've just had a question about whether this will be able to watch again. Yes, this is being recorded, and it will go up onto the EDFN website. So if you're not already a member, please go to edfn.org, sign up there, and you will have access to this recording of all of the presentations today. So moving on, we now have a delegate address from the company who've sponsored this afternoon, Dermatonics.
Thank you very much. Right, I've just got 5 minutes to talk to you about Dermatonics. So hopefully some of you will be aware of the product already. So I'm going to take you through a number of slides just to... Sorry, can we move on to the next slide? Thank you. Right, the Diabetic Foot Journal in March 21 came across, there was a roundtable discussion of which some members of that working group are here today, so I'm not going to insult your intelligence by repeating this. But essentially, there was a call for more daily applications of urea-based cream. So urea is obviously important. It's present as a natural moisturizing factor in the skin anyway. But what Dermatonics we've done is put a 25% urea product out in the market, so it's keratolytic. It'll actually get rid of these bits of dry skin and hard skin. Next slide, please. So what you want from your emollient, you want it to be safe, effective. You want it to be shown to be clinically effective, and also obviously there's cost effective at the end as well. Next slide, please. In terms of safety, the Dermatonics Once Heal Balm is actually classed as a medical device class 1. So if there are any issues, we are obliged to report it. And I can happily say that we've sold over 1 million tubes, not just in the UK, but across the world. And so far we've had one pretty minor case of sensitization. So it literally is 1 in a million. So you can consider the product as being safe. Next slide, please. In terms of its effectiveness, this is a scale, a hydration scale taken from corneometer testings, and the corneometer testings were done on one patient. So our product went on 1 foot and the competitor product went on the other. Number of patients involved, and basically at the end of that we can show that the unit hydration lent to the skin by using Dermatonics 25% Heal Balm is higher than the competitor products. Next slide, please. We also wanted to show it was clinically effective. It's all very well coming in with numbers and saying how many grades we can move the skin hydration up. So again, in the Diabetic Foot Journal back in 2020, I think it was about a month after COVID hit us first time around, an article was published in the journal to look at how effective Dermatonics Once Heal Balm was actually in the clinic. Next slide, please. This was a result of two studies. We used the skin scale, which some of you would have been introduced to back in 2014 when Matthew Young and Mike Townsend got together and produced a photographic skin scale to make it easier to talk to the patients, but also easier for GPs and practice nurses to discuss dryness. What is dryness? At what level do you need interventions, etc. So this scale is not aimed at podiatrists because you know skin. But this was launched in 2014, and we use it as a base when we do studies, just so we can show improvement. Next slide, please. So it was a two-center study. Whittington first, they got 49 patients together who were in level 3 and 4. I know you've seen a lot worse in level 4, but this is our primary care intervention scheme. So of those 49, 96% of them moved from level 3 and level 4 back up to level 1 and level 2, which we regard as a safer level. Bearing in mind, this is a once-a-day application, so that's 14 applications. Next slide, please. The other half of the trial was done up in the Highlands. They got 82 patients up there, and again, all 82 were classified as either level 3 or level 4, and after 14 days worth of treatment, once a day, about 90% of them moved up from level 3 or 4 up to level 1 and 2. Next slide, please. The other thing we did, we got involved with an inpatient improvement program. And what happens there was when the patients came in, they wanted to reduce the hospital-acquired ulcerations within the wards. So patients were identified as being at high risk. And part of that program was the application of Dermatonics Heel Balm to the heels. So this was done using sachets, because if we put tubes in wards, they tend to go missing. But if you're using sachets, you're controlling the dose for each patient, and you're also preventing any cross-contamination issues. And we're happy to say that after a year, they estimated it's prevented 19 ulcers, which is fantastic news for patients, but also from a hospital point of view, there's a significant savings there. Next slide. Cost effective, this product is used once a day, whereas the vast majority of our competitors are twice a day, so you're already using less. And on prescription, our product is slightly cheaper per tube anyway, so we can show cost effective. If you're interested in the actual numbers, I can send them to you at a later date. Next slide, please. So what do you want from your emollient? You want it to work. This particular one, urea is 25%. That's the active ingredient. There are a whole bunch of other ingredients which help that function more and gives the cream its consistency. Patients don't like smelly stuff. They don't like greasy consistency. So we worked hard to put that urea 25% into a presentation that pleases a patient. We've got proven hydration. We've proven it to be effective. The study that Sandra Jones did with Daniel Lund from Oxford, he's a statistician, not only did we prove we moved more than 90% of patients from level 3 and 4 up to level 1 and 2 on the skin scale. What the other sort of side effect happened was that the patients who were coming in and using Dermatonics Once Heel Balm were actually going longer between podiatric appointments as well. So that was an unexpected benefit that we saw. We know it's cost effective because, as I say, it's just once a day, and the product is slightly cheaper on prescription anyway, and we've got a good safety record. Going back to the original slide where the round table within diabetic foot discussions looked for more urea-based creams to be used, this is available on FB10 for prescription. Next slide, please. And just in case some of you are out there and you don't like to use 25% urea all the time, Dermatonics is fine. You can carry on using that. But if some of you prefer to go down to a 10% urea, that's fine as well. We've taken care of that for you. This is paraben-free, it's hypoallergenic. And again, this is available on prescription. And final slide, please. So if you want to try it for yourself, I can talk to you all day. Believe me, 5 minutes is 300 seconds isn't much time to discuss the products. I'm happy to come along to staff meetings or study days, whatever. Webinars are fine, but there's nothing like getting a bit of the Dermatonics Once Heel Balm on your hands so you can see what it feels like, what it smells like. If you want any samples of the Heel Balm or the dry skin balm as well, I'm more than happy to send some out to you. We're pretty generous with samples, generally speaking. Just email me at that address with your preferred clinical address and we'll get them out to you after the bank holiday. Thanks very much for your time.
Gareth, thank you very much. And again, thanks to Dermatonics for sponsoring us this afternoon. Moving on, we now have a patient's perspective. Possibly one of the most important things is actually listening to the experiences of our patient cohort. And in this recording, we have Sue Matthews asking her brother, Andrew Deakin, about his experiences.
What did you understand about diabetes and the impact on feet before you developed a foot problem?
I didn't really think that there was a very large chance that I would be affected by diabetes with my feet. I saw my diabetes as a bit of an inconvenience, that I was big enough and strong enough that that wouldn't affect me the way that people said that it could. So yeah, I didn't really think that there was a major issue with feet.
What really mattered to you when you were first diagnosed with diabetes? I'd just turned self-employed when I was first diagnosed with diabetes, and I was probably more concerned about the time that I would have to take off work for hospital appointments, and if it did affect my ability to work, rather than what it would physically do to me. Can you describe your first visit to the foot clinic and how you felt?
My first visit to the foot clinic, I had quite a large abscess on my toe, and I basically thought I was going to get a bit of a telling off for not looking after myself as well as I should do, and basically to have a bit of a plaster put on it. The conversations that happened after that initial wake-up call as I was sat on the bed kind of made me open my eyes.
How did you find out you had a limb-threatening problem?
As I said, when I went to the foot clinic, I was sat on the bed, had the dressing taken off my toe, was sat there quite jovial and having a laugh with the people that were knocking around, and the podiatrist came in and examined my foot, and I was told that there was a possibility that I had a Charcot foot. Again, until that's actually explained to you, you don't really know how severe that is. But my podiatrist sat me down and explained everything about it.
At what point did you realise the seriousness of your foot condition?
After the podiatrist had explained about the Charcot foot, I really had started panicking slightly inside. Like I say, I was expecting a plaster slap on the wrist and told to go and look after my blood, my sugars. The diabetic doctor was in clinic that day, and he came and had a chat with me as well. He said to me that within 6 to 12 months, I would have problems with my kidneys and with my eyes. And within a couple of weeks, I was at the eye hospital having injections, and my kidney function had dropped.
What were the causes of your foot problem?
I think the biggest cause of my foot problem was lifestyle. I used to drink too much. I also smoked. I was working very long hours and commuting quite a long way to get to work.
In the industry that I work in, we're always working to timescales. So you might not get any lunch. You might eat your lunch while you're working, in which case you weren't doing your finger pricks, you weren't taking insulin. So my blood control was out of control.
You developed Charcot foot and a foot ulcer a few years ago. How is this being managed and how does it affect your day-to-day life now?
The Charcot foot's being managed. I still wear my insoles in my shoes. The foot ulcer is healed. I've still got the scar on my foot, but that's all I'm doing.
What impact did being treated by a diabetes specialist podiatry team have?
I don't know what treatment would have been like just by a normal podiatrist, but this diabetic specialist team treated me really quickly and opened my eyes to the fact that I probably would be dead. I'm not doing this interview now if they hadn't have acted as quickly as they did.
What do you wish you'd known about diabetes related foot issues that you know now?
I think, to be brutally honest, you could have told me that there was a chance that I would lose a leg. There was a chance that I wouldn't be able to feel my legs on my feet from the knees down. And I would have thought that you were just scaremongering me.
Do you think there needs to be different education around the risks of amputation and early death for people living with diabetes?
Yeah, I do think that the seriousness of the side effects of diabetes is something that I don't think it's driven home. I remember once being told by my diabetic nurse that, you know, we can always fiddle with your insulin and we can make you, you know, lose weight and we can use it as an advantage. But there was never really any emphasis put on the downsides to the disease.
Was there anything that surprised you in your dealings with NHS services?
Before I started having any real issues, I was running my own business and I could be held up in meetings or not be able to make appointments because something had happened at work. And I did miss a couple of appointments and ended up being struck off the list. So my diabetes was then controlled at the doctors rather than at the hospital. I don't know whether after the pandemic, whether Zoom meetings would be a better alternative, or maybe more phone calls. I don't know, but once I was struck off, then I do believe that my control got worse. Not that, you know, that it's still all my fault, but I think there could have been other ways of dealing with it.
How has diabetes affected your health and your life?
That's quite a big question. And since my conversation with the diabetic doctor about the eyes and the kidneys and everything else, I've been having injections in my eyes to help cure diabetic issues. My kidneys failed and I did time on dialysis. I had a kidney pancreas transplant, which again could have been a very different story and had a very bad ending again. So every day that I get up now is a bonus, because I don't think I'd have lasted longer than a year or two in the condition that I was in.
What would you tell your younger self, knowing what you know now?
Oh dear. I tell everybody and anybody that'll listen that's got diabetes that they need to stay on top of it. I know the blood testing is the key to it, which is something that I didn't do a lot of. What I would have told myself would be to do more blood testing. Whether my younger self would listen to my older self, who knows? But yeah, the key to it is the testing. Now, whether these new ones that you see where people are testing with the strip on their arm, the implant, it seems to be the way forward, because the testing is very painful on working hands, but it's got to be testing. That's what you need to do.
You mentioned previously an issue with accessing services due to working. How do you think NHS services or workplaces, or both, could help people to manage their health better?
I think the NHS staff are going to love this, but I think evenings and weekend would be the obvious answer. I think telephone calls or Zoom calls would definitely help. And as far as employers go, you know, a lot of employers, especially in my industry, they don't want to hear that you've got a hospital appointment or you've got issues or you need to do this, that and the other. They just want you there to be working. So I think employers need to sharpen the game up, but it's also down to the individual. They've got to say, no, I could work for you for 2 years. If I drop dead, you'll just replace me. You'll just get somebody else in. So the employers don't care about your health and safety. You just got to sort yourself out.
If you could give some feedback to help reduce foot ulcers and amputations in people with diabetes, what would it be? How could things be improved for people in your position?
I think, as I said before, one of the things that was one of my biggest issues was finger pricking. And I think the constant monitoring where people scan the back of their arm or wherever the scanner can go, I do think that is definitely the way forward. If there's any way of connecting that to a pump, which is basically acting as your pancreas, then that would be absolutely fantastic. I think the other way would be with a support group of some kind, where people that have been down the road and been fortunate enough to survive it, or have seen the light and are now dealing with it. I think it would be really good for them to share their experiences and to answer people's questions as somebody that's been there and done it or not done it. as opposed to a nurse or somebody that's reading it out of a book.
What was the catalyst that made you change your lifestyle?
I think the biggest thing that sticks in my mind is the diabetic doctor. He was quite frightening, really. Some of the things that he said really made me sit up and think. One of the main ones was my eldest child was about 14 at the time, and he said, if you want to see your daughter get to 18 and to be able to go to the pub with her, you need to sort yourself out. If you don't make changes to your lifestyle, he basically said that I had 12 months to live. And that makes you think. I came home, I was worried, I had a cry. I stopped smoking almost instantly. I didn't need any help. When you're told something like that, you don't keep putting it off, you stop. I did try to look after my blood sugars a lot better, and I was controlling them quite well, but the damage had been done. So I think that if the doctor hadn't have said it in the way that he did, if it had just gone, you need to stop smoking and need to stop drinking, I probably wouldn't have. He gave me the wake-up call that I needed.
Well, thank you very much to Sue and in particular Andrew there for an open, honest, very personal and thought-provoking discussion. I will leave you with that to ponder for the next quarter of an hour. We'll have a quick break and I'll see you again at 3:30. Hello and welcome back, everybody. At this point, I'm going to hand over to our host chair, Derek Thomas. Derek's MP for St Ives, West Cornwall and the Isles of Scilly. He's currently a member of the Environment, Food and Rural Affairs Committee. And alongside his constituency work, he has many roles in Parliament, including several in healthcare. He was a member of the Health Select Committee and has been chair of the All Parties Parliamentary Groups for axial spondyloarthritis, brain tumours and radiotherapy. Also, he was chair of the Venous and Vascular Disease APPG group and is currently ABP chair for diabetes. So I think that probably makes him the perfect chair for our next discussion. Thank you, Derek.
And thank you for that introduction. And I'm here in my office in West Cornwall, and it's great to be joining the English Diabetes Foot Care Network Conference. It's an interest that is a particular one of mine because as a South West MP, right down the end of Cornwall, sometimes healthcare is difficult to get access to. But when I first got elected in 2015, I was informed that actually lower limb amputation was as bad, if not worse, in the South West as anywhere else in the country. So we did quite a bit of work, and that situation has improved, but I've maintained an interest. But I also maintain interest because access to podiatry and podiatry training is also challenging, and there has been times in the South West, in Cornwall in particular, where you just could not get access to training. So this is an area I'm really interested in. I'm very pleased to be able to speak. Thank you. So the question for our session this half hour is, podiatry, is it essential or dispensable? I know the answer to that, but I've got we've got two speakers. I'm getting some terrible feedback. I don't know if that can be addressed, but I'll be brief. Professor Michael Edmonds is going to be answering our questions, and Dr. Leanne Atkin. Can I start with you, Dr. Leanne Atkin, and ask if you can just maybe pitch yourself for a minute, tell us who you are, what your particular interest is, and then if we can go straight to Professor Michael Edmonds, and then we'll take questions. Thank you.
So thank you very much for this invitation. Diabetic foot and the management of the patient with diabetic foot disease has been a passion of mine for many, many years. And I bow down to Professor Mike Edmonds at any opportunity I can to actually steal a little bit of those brain cells, because he's absolutely fantastic at this. So it's great really to be here with a rather controversial session in terms of, is the role of podiatry essential or dispensable, or even worse, could it be replaced by a nurse? So I look forward to this session.
Thank you for that. Professor Michael Edmonds, can you just pitch yourself for a minute and then we'll go straight to questions. Thank you ever so much, both of you, for the time that you're able to give this afternoon.
Okay, I'm a consultant diabetologist working at King's College Hospital, and have had an interest in diabetic foot care over many years, and set up the Diabetic Foot Clinic at King's College Hospital some 40 years ago now, and the aim was to reduce amputations as much as we could.
Thank you. Well, while people have the opportunity to put questions, ideally in the question answer function, but if not in the chat, I'm going to start the conversation off because you'll be aware, and I'm going to be a little bit controversial here, you'll be aware that government and the health and care bill that's just passed through Parliament, the issue around workforce was a real bun fight, and I, on several occasions, voted against the government and with Jeremy Hunt and the Lords on workforce planning. And I did that because of the challenges we saw in the Southwest for lots of areas, but in particular, or rather as well as podiatry and the need for podiatrists, because I would argue that it's essential in the pathway of diabetic care. What do you think, Professor Michael Edmonds, about how we should properly plan the workforce, in particular around diabetic foot care and podiatry? Is there an answer? What would you be telling ministers if you're in my privileged position?
I would say that the diabetic foot has a very complex natural history. It's very complicated. It proceeds very, very quickly. An infection can destroy a foot in 48 hours, and if it's not treated, it can kill the patient. So that's what we are dealing with, and we need action very, very quickly. And for that, we need the patient to get to help rapidly, and that expert help to be available. And the gatekeeper, the coordinator of this is the podiatrist. Derek, I'm not sure how we're going to play this. We did have a few slides ready to sort of explain this situation, but I don't know whether you want to go for a sort of an ad-lib free-for-all, as you wish.
No, Professor Edmonds, do use those slides. That's brilliant. You take whatever time you need to provoke questions. We've got till 4 o'clock, so you fire away, yeah.
So, Richard, are you online? Should we go for the talk or as such?
Yeah, yes, fire away, Mike.
Okay. So a share screen. There. Okay, and we'll go. Yeah. Okay. Role of podiatry. Okay. So in this talk, I'm going to do two things: highlight the disappointing situation of diabetic foot care in England, and make the case that podiatry is crucial in improving this situation. Recent data: the number of major amputations is increasing in person with diabetes in England. This shows the data over 3-year cycles from 2012 to 2020, and you see a steady rise in the number of amputations. Now, because the number of diabetic people have increased, the actual rate of amputations is static, it's about the same, but it's not falling. And this shows the rate, number of major amputations per 10,000 population years over the 3-year cycles, 8.1 but 8.2. But within this, there are very disturbing variations. So this is the five-fold difference in amputation rates in CCGs throughout England. And you've got the line there, straight line there of the 8.1, but there are 13 with amputation rates above, significantly above the national standard. And geographically, I'm slightly reluctant to show this slide now, Mr. Thomas, but this shows the quintiles of standardized rates of amputations from the top, the heavy, possibly black areas, and you can see they are present up at the north, and they are also present, I think that's Cornwall, actually, Mr. Thomas, but those are the figures. Now, the clinical burden, the figures are even worse. The clinical burden is not fairly situated throughout society. The rate of major amputations, as this graph shows, which is on the x-axis, is shown here against levels of deprivation on the y-axis. And the rate of major amputations in the most deprived areas is 1.82 times higher when compared to the least deprived. And this goes along with what a surgeon that I knew some time ago said, gangrene is a disease of the poor. And that's really not acceptable in this day and age. So what is the reason for all these major amputations? The diabetic foot is complex. It's got an aggressive time-dependent natural history, as I said, and this defeats healthcare systems because they do not understand the time dependence of the history and have not adapted to it. So I'll quickly go over this. I don't want to make this complex, but I just want to show the situation. We have in diabetes, we have a neuropathic foot, mainly neuropathy with ulceration and Charcot, and we have an ischemic foot where there's different sorts of scenarios. Neuroischemic with neuropathy and ischemic, critically ischemic, acutely ischemic, and renal ischemic foot. Now, don't worry particularly about the full details. I'll show you pictures of these in a second. So the foot goes from normal, high risk, ulcerated with tissue damage, threatened, and then to necrotic and gangrenous. So pictorially, we have this. We've got the neuropathic foot, it gets an ulcer, it gets infection, and it gets gangrene. We have a neuropathic foot, it gets trauma, and we get the Charcot foot, bone and joint problems. It gets deformed, ulcerated, infected, and gangrenous. Then we have the neuroischemic foot, which gets ulcers on the margin. It gets infected. And it gets gangrenous. Then we have the critically ischemic foot, where there's a marked reduction of the blood supply. This leads to necrosis and gangrene. We have the acutely ischemic foot, sudden massive reduction in blood supply, blue foot, mottled foot, dead foot. And then we have the renal ischemic foot with, we see a lot more people on dialysis now with these little necrotic patches. So this is the situation. These are these horrible histories going on as we speak in England. Well, in fact, it's going on all over the world. And what are we going to do about it? Well, let's go on to the next slide. Important to restore control and treat rapidly as possible because time is tissue. So we've got to get control of the wound, the vascular, infection, mechanical, metabolic, and educational aspects. And for that, we need a team: podiatrist, nurse, orthotist, diabetologist, surgeon, various people, and interventional radiologists. And NICE has recommended in their NG19 for foot problems that active foot problems in person with diabetes should be referred within 1 working day to the multidisciplinary foot care service, and for triage within 1 further day. But there's a problem. Usually that diabetic foot team, the multi-team, will meet once a week. So how are we going to provide care and assessment daily by the multidisciplinary team? And for this, we look at the podiatrist and also to a certain extent, the nurse. But I just want to point out the podiatrist has a great role in the early treatment of the foot. It's stage 2, the foot is intact, there's no ulcers along here, and it's a protective, preventative action for which the podiatrist is extremely skilled. But unfortunately, the skin does break down in some cases, but the podiatrist can treat this ulcer on the plantar foot, can recognize the Charcot foot and put a patient in a cast and treat the ulcer in the ischemic foot. And also with all these ischemic scenarios, the podiatrist can assess what's going on and assess the degree of ischemia and bring in the vascular surgeon. So podiatrists have an important pivotal role. They're essential gatekeepers and coordinators in initially assessing and diagnosing, ensuring patients see the right multidisciplinary specialist, and should be central to planning and implementing a multidisciplinary care. Once you get to stage 4 and 5, infection and ischemia is running amok, and then you've got to have the whole team, but podiatrist is important in that. So just from our example at King's, the podiatrist takes part in the healing of ulcers, accepting of referrals, the vascular clinics, the orthopedic clinics, the outpatient antibiotic, debridement minor surgery, post-operative reviews, Charcot foot clinics, education and research, and the coordination of primary and secondary care. Now you may say, well, if they're so important, what happens when they're withdrawn? In Norwich, there was a 50% reduction of staffing in Norwich, and what happened? Clinical activity fell 18%, admission rate went up 50%, and length of stay 12%. And in Arizona, there was a withdrawal of reimbursement for podiatry, and what happened? A 137% increase in mortality and amputation, also increase in sepsis and surgical complications. So as a diabetologist, I am forced to conclude that the podiatrist is essential in the care of the diabetic foot. The podiatry workforce should not only be preserved, but actually increased to improve the disappointing situation of diabetic foot care in England. So, Mr. Thomas, if you're agreeable, Leanne was now going to go on and give her talk, and then we're going to invite you into as a discussion, if that's okay.
Yeah, no, that's brilliant. Thank you very much.
Okay.
Thank you.
Okay, Leanne, I'll stop sharing.
So I'll just attempt to share. So this might be slightly difficult because I've had to use my trust computer. So hopefully, if bear with me. So if I share my screen first, hopefully you can see my laptop and you can see my slides. If somebody could just let me know,
yeah.
I can't see the screen.
Yeah, brilliant. Thank you very much.
Brilliant. So thank you so much for this invite. So given the title by the Royal College of Podiatry to ask whether the role of the podiatry was essential or dispensable was a really interesting topic, and it really made me think. It made me think about actually what is the role of the podiatrist within the diabetic MDT. And actually, as Professor Edmonds has explained, that their role is multifactorial. It's that ability to diagnose, monitor and escalate foot conditions, those excellent blade debridement skills, their expert wound knowledge, the knowledge of advanced wound therapies, expert in offloading. It's that case coordination which we really need. But, there are some great other aspects in terms of education, peer support, audit and leadership. And I know some fantastic podiatrists such as Sam over in Manchester, who leads from a consultant perspective the whole of the diabetic foot service. But actually, could Sam be replaced by a nurse? And I say that because within my organisation, we do not have the role of the podiatrist within our most complex foot service. That's not for the want of trying. The issue is we simply don't have the number of podiatrists able to come and help us to staff that most complex of clinics. So actually, is that role essential, or could a nurse actually replace that role? When you actually think of the undergraduate training, you have to start to answer the question of yes, we don't actually need that distinction, because when you look, we are all professionals, we've all got that graduate ability, and we're all assessed in terms of that ability to diagnose, recognise and escalate, making us a safe professional, whether you're a nurse or a podiatrist. And if you look at the NHS England and Skills for Health frameworks, actually the workforce of the future shouldn't be bound by a profession or an academic qualification. It should be really based on an individual capability. And why is that? Well, you get the best out of your professional by thinking of that way. So rather than silos them in certain groups, thinking about who is the best to do that. So, you know, we've got an emergence of vascular podiatrists playing in the role of vascular nurses. You've got non-medical consultants now playing at that consultant level. And working at the top of that license really allows us to expand that, which is ultimately better for patients, better for the service, and better for the professional in terms of satisfaction. But actually, when you start to dig down about what is our undergraduate education, a nurse's undergraduate education is extremely broad. It really includes the whole of the health and the well-being of that patient. There is very limited wound care education in the undergraduate training of a nurse. There's about 6 hours per year. There is very limited anatomy and physiological about the foot in itself. And there's absolutely zero education about biomechanics, offloading, blade debridement, or differential diagnosis. But even if it's not there in the undergraduate programme, you can get these skills and this knowledge like I have with my postgraduate education and my clinical practice. But there is something unique about the podiatry education. Then actually the whole of their 4 years is actually really focused, 3 to 4 years, is focused on the foot in itself, relating to the function of the foot, the disease of the foot, the medicine of the foot. And if any of you's ever worked in the foot, the one thing that I'd say is it's a complicated space to be playing at. So when you start to think about the role of the podiatrist, you can start to think about actually, you know, when you think about Sam's non-medical consultant role, actually some nurses can do that. But you've got to remember that actually the majority of the nurses out there cannot function at this level and have not got those undergraduate skills. The only people that come out with the right amount of level of education and knowledge from an undergraduate point of view is this very essential workforce called the podiatrist. And the reason why we need that workforce is the varying range of conditions. So the management of that acute infection, thinking about that urgent escalation, it's about having that knowledge of those underlying structures of where it's safe to debride or not. It's about recognizing how we offload things that are outside of the podiatrist's normal practice, such as a pressure ulcer on a heel. It's about thinking of that underlying arterial disease and doing the most complex of wound management. But all of these pictures that you see here, actually, I can do as a nurse too. But actually, my skill set is very limited, because where the role of the podiatrist really excel is that actually they're able to think very much about the function of the foot. They are able to understand loading pressures of a foot that I cannot understand. They're able to really differentiate with foot pain. I can tell you whether it's arterial or not, but I've got very little differentials to come to you. The podiatrists are trained in that diagnosis of what that foot pain could be. They have huge amount of hours of lectures of the biomechanics of the foot. I know very little about this. And as Mike's explained, you're talking about how to manage the acute Charcot foot or how to offload the most difficult of patients. And even when we see patients like this in our clinics, these are the type of patients that I do not know how to offload. I simply speak to our podiatrist to say, please offload this, and basically drop that bomb and run away, because I do not know how to offload such a complex foot. I think, though, that we've got to understand why are we having this debate in the first place, and actually we're trying to find solutions for a workforce that's in crisis. We've heard that nursing workforce are in crisis, and unfortunately, nurses get more media attention. I think actually when you look at the numbers of the podiatry workforce, this is truly shocking. How can the number of patients with diabetes be increasing so far, but the numbers of actual podiatrists are dipping down? I couldn't believe that there is only just over 12,000 registered podiatrists across the UK. You know, that is a significant shortage of one podiatrist per 5,500 residents across England. And the numbers of the podiatrists are declining year on year because of the age demographic of the current workforce. You've all heard about the impact from a political point of view about what happened with the withdrawal of nursing bursaries and what happened once the withdrawal of the nursing bursaries in 2016. Surprisingly, the number of applicants who wanted to do nurse education dropped like a stone. But the same thing happened to podiatrists. The same thing started to happen with them losing their bursary in 2016, and the numbers are declining. How on earth can we only qualify 126 podiatrists each year and plug this workforce gap? And despite the pleas to increase the commissioning, this hasn't happened. We've had year on year decommissioning of HE funded places for podiatrists. And even the reinstatement of the £5,000 bursary, things are not getting any better. And I don't think that we can come away without saying that, you know, and it's great that we've got an MP here, and I'm sure that you as an MP understands the power of the media and the spin on this. You've all heard about the fair pay for nurses and that the pay award is an insult to the NHS heroes being nurses. But can I tell you, podiatrists are on the same pay scales as us. We're on the same banding. We have the same agenda for change. Their pay has exactly been impacted the same as a nurse. We haven't had a real-time pay increase for many, many years. And this truly impacts on the retention and recruitment of people into the podiatry profession as much as into the nursing profession. And just to bring home the media spin, you know, during COVID, nurses were called heroes. Actually, podiatrists were demonised. You know, the Daily Mail said that some podiatrists were just sat around twiddling their thumbs for months during the COVID crisis, whereas nurses are heroes. How is that true? Because I can tell you that many podiatrists across the UK helped the burden of wound care. They started to take over wound care of things that no longer were on the foot quite happily. Many podiatrists learnt the art of compression bandaging. Sam Haycox is now an absolute whiz at compression bandage. Justin Tansley down the south absolutely loves a bit of compression therapy. And all of these have got huge transferable skills. But they also really helped us in that diagnosis of the COVID toes when that diagnosis was a real unknown. They really helped us to actually manage that acute limb ischemia caused by the thrombotic response of COVID. They helped us to recognise these patients, escalate these patients, and keep these patients safe. And unfortunately, they continue to help us with the vaso injuries caused by the life support of keeping these patients alive who had terrible COVID sepsis. And the podiatrists play a part in all of this and was extremely active during the COVID, but nowhere in the media was that ever reported. And I think it's important when we talk about podiatrists, it's not just about feet. You know, the likes of people like Martin Fox, who have really revolutionised the podiatrist's role in peripheral arterial disease. And, you know, when you think about that burden of saving lives and saving limbs, you know, what that's the podiatrist college is asking to do is really prevent that cardiovascular disease, catch it early, stop it becoming a problem, stopping it becoming a burden to the NHS, ensuring that patient lives a long, healthy life. And now the Royal College of Podiatry are asking podiatrists to help to detect AF, the #1 cause of stroke. And this big well-being role that they can play in primary care, secondary disease prevention cannot be underestimated. So actually, the conclusion I have is podiatrists is an absolute essential part of our workplace. They're not replaceable. They're not even replaceable by the most highly skilled of nurses. We need to be investing in that podiatry now, because actually that lack of investment is leading to poor care and poor outcomes and higher costs right here, right now. We need the podiatrists to help to prevent that further prevention of disease. Surely that's where we need to be focusing our resources on. But we also need it to limit the disease, to reduce that impact of that morbidity, mortality, and amputation. So actually, there's a tsunami heading towards us. And we need the podiatrists if we're ever going to survive that tsunami that's about to hit. Thank you very much for listening. I hope if you've got some questions.
Thank you, Dr. Leanne, and for Professor Michael Edmonds. Thank you for that. It certainly refreshed my memory, about what this looks like. Sorry, Dr. Leanne, can you mute your Zoom, because I think it's you that's causing the thanks. Well, we haven't got much longer, but let's take a couple of questions if we have them. Let's start straight away with Jessica Isa. I'm assuming that's how it's pronounced. Not many youngsters are aware of podiatry, and many people it's not appealed in treating feet. The removal of bursaries caused a crisis in the workforce. It seems that the government eventually acknowledged their mistake and re-established the bursaries. What about the use of middle cohort that has left uni with huge debts? We definitely need to be promoting more and more podiatry out there. I would agree with that, and I particularly think that it helps rural areas like mine, where actually career progression is more challenging. I don't know if Dr. Leanne, would you want to have a go at that one? This is about how do we actually access some of the skills there to move to podiatry.
I think that question brings a couple of points, really. The first off, that middle cohort that's come out of that university with a hell lot of debt. You know, I feel so sorry for that cohort of our profession, and that's the same across the board. There's a number of nurses that's at the same time, and unfortunately, I don't think there is any solution for that. I think that the thing that we need to do is to ensure that those professionals have a good lifelong career progression within the NHS. So the one thing they do not do is to leave, and therefore that becomes a financial wasted burden. I think that we need to make the podiatry career path more attractive. I think that, you know, I'm very fortunate to be a consultant nurse. Consultant podiatrists are few and far between. We don't have such a role in our organisation. And I think that if we can actually make the career pathway more attractive, I think that that's when we become to retain our staff. I also think there's something that still needs to be done in a very junior level of how do we attract the apprenticeship role right from you know, leaving school. How do you actually make them want to be included? And I still think there's something to be done about the perception of podiatrists being the nail cutters. You know, I still think there is some work to do to show the breadth and the depth that these roles have and play this essential role.
Thanks for that. You've answered brilliantly, Leanne, a couple of other questions there at the same time, so thank you for that. But for Professor Edmonds, sorry, would you say there are other professions you might consider essential as part of the multidisciplinary team, or just beneficial? It's a little bit off the subject, but it'd be interesting to hear very quickly, what other professions you believe are absolutely essential to the pathway for diabetic foot care?
Yeah, well, in the early stages of disease, then, as I pointed out, the podiatrist and nurse is important. But when you have infection and ischemia, of course, the role of the surgeon, the vascular surgeon, is important. With this complication, Charcot, the role of the orthopedic surgeon is important, and the diabetologist is important in admitting patients and treating the infection in conjunction with the microbiologist. Essentially, it's basically an orchestra. You know, you need the percussion, you need the wind instrument, you need the strings, and you've got to bring them all together. But an orchestra needs a conductor, and I think in most hospitals that should be the podiatrist who can be there most of the time. I mean, in specialized centers, I think also a diabetologist may well be helpful working with that. But no one person can look after the diabetic foot. It's got to be a combination of these various features, but bringing the whole thing together.
Brilliant. Thank you very much for that. I really do appreciate that. Sorry, the questions moved. I've lost what I was going to ask you. Yeah, so apprenticeships. In Cornwall, we have the Health and Care Academy, which is really working to try and allow people to stay closer to home and train and get a profession within the NHS. I'm not absolutely sure if that includes podiatry. Would you want to be seeing apprenticeships in podiatry? Is that something that can be achieved if it's not already? And I don't mind Dr. Leanne or Professor Michael who tackles that one.
Well, I'll start. Absolutely. You know, the apprenticeship route has always been the better form of route, if you ask me, but you're asking a very old nurse. I trained in my local hospital, who lived in their local tower block and had their education on the ward and never went to a university. You know, there's something about that. If you don't feel academically gifted at that point in your life, there are ways that you can actually learn a professional skill. And what happens with those type of individuals is that they become wedded to the organisation. So that investment, actually, if you look at all of the old-fashioned trained nurses, you look at the new apprenticeship for nurses, they stay within the organisation that actually built them. And that's what we need to be thinking about, having that stable workforce going forward. And the reason that, you know, podiatry is the fantastic position for that. But I think the thing is what we have to work out is, yeah, how do you get them from students, college level to qualified, if you like, but we also need to sort the other end out. We need a career progression plan, which could be an apprenticeship route still, from that qualified podiatrist to the consultant podiatrist, because we are losing so many people. I work with a fantastic podiatrist on a Friday morning. I've just been with her this morning. She's been on the same pay grade now for the last 15 years. How is that appropriate? You know, it's because there's nowhere else to go unless she moves organisation. You know, we need to think about that lifelong career structure.
Thank you for that. Professor Mike Edmonds.
Well, I go along with the same thing. When we work as a team in the diabetic foot clinic, there are various roles and needs, and the apprentice can carry out a very important role in the care of the both actually nursing and podiatrist, from the point of view of assessing the patient, picking up an early diagnosis, and under supervision. The apprentice will work under supervision and will, I think, thrive. We've got to put forward this team approach. And although there may be different people at different levels, in the end, I think the contribution of each person is very important.
Brilliant. Thank you. We're going to have to leave it there, but I wonder if Dr. Leanne and Professor Michael, if you're able to, if you can respond to the questions that are in the Q&A session or Q&A section of your Zoom or in chat, that'd be helpful. If that's possible, but otherwise we're going to have to leave it here because of time has beaten us. But thank you both of you. It's been brilliant to be reminded of the
Mr. Thomas, could I just say that I think I didn't wish to highlight Cornwall on my map, but I think Chris Whitty, the Chief Medical Officer, has really, I think, highlighted that, you know, poverty is a feature of many country areas and and seaside resorts, and I think of all the features that are affecting diabetic foot care at the moment, I think is deprivation, which we should also address.
I think that's right, and that's driven by often rurality and the fact that it's so difficult to get to people to provide care. The work we do in Parliament with the diabetes APG is looking at how you can actually use more and more digital and more other solutions to try and manage people's care. But there's nothing that you can't beat someone actually checking a foot and making sure there's the right care and support and information for that patient. So thank you very much for both of you for your contribution. And if you can tackle those questions, that'd be great. I'm going to leave it to you to do that. Thank you.
Thank you.
Wonderful. Thank you all very much to Dr. Liang Atkins, Professor Mike Evans, and for Derek Thomas for chairing the session. I think that probably could have gone on a lot longer, but we are a little behind time, so we must move on. And we're going to move to health inequalities and access to services. The speaker, Nur Alam, is a specialist podiatrist community care in care diabetes, and will look at issues facing different population groups in accessing healthcare services. He specialises in research development and is an audit lead, and will deliver this session. And we'll also cover how NHS England has reduced practical resources to help improve access for all and reduce inequalities in access. Thank you.
Thank you very much, Richard. Hello, everyone. Thanks for the introduction. So just to begin then, I'm a community podiatrist specializing in diabetes, and I've developed a particular interest in tackling inequality, health inequalities, particularly after recent research on looking at major contributory risk factors leading to diabetic foot tissue damage. That led to certain results and conclusions, which suggested certain category of people from certain social backgrounds, from different areas of the country, and many other factors, many other reasons. For some reason, they weren't accessing community health services and were going to secondary healthcare services, and after great tissue damage and leading to amputations, which is quite sad in the sense that having been worked as a community podiatrist for some time, as Mike Edmonds clearly and Dr. Atkin, sort of I'll just echo what they said, it's very important that they don't bypass us, as we as podiatrists, as we know, can from the community setting minimize people going to ultimately to have an amputation. So it's a special interest of mine, and you know, it's not going to be very long, but I'll just tackle the main areas. As an example, what I'm going to do, actually, I've just realized I'm just going to share my screen. Hang on a minute. Let's have a look. Can everybody see that, Richard?
Yes, we can see that.
Fantastic, fantastic. Right, here we go. Okay. Right, so just to put it out there, there is a legal framework. You can see it in the NHS England, in the public NHS England site, which gives guidance to CCGs and employers, leaders of national and local systems, the fact that there are legal duties, and this good document really gives guidance into health inequalities, just to put it out there really. Just to move on, just to give a bit of background and just as a reminder for those of you who already know how important diabetes and foot disease is to highlight very quickly that around 6% of the population of UK is estimated to have diabetes, which equates to about 3 million people. And just under 24,000 of adults live with diabetes. And one of the most, as we know, significant diabetic complication relates to tissue damage, which we see as podiatrists as foot ulcers in our clinics. And the lifetime risk of developing a foot ulcer with somebody who suffers from diabetes is said to be around 25%. Okay, just going to move on. Right. So exist in diabetes, health and other care systems. We've seen particularly these inequalities starkly surface during COVID-19 pandemic. It's been widely reported, I'm sure you are all aware. Inequalities is to sort of investigate inequalities and to put it right is not simple. It's quite a complex sort of task. It's very complex in the sense that there are many things that feed into inequalities. So there's environmental factors, as Mike Edmund mentioned, deprivation is quite a key one. We're going to talk a little bit about that later on. There's which links to socio-economic factors and genetic risk certain individuals have of developing diabetes related sort of conditions. Social factors stemming from socio-economic and environmental factors such as ill health and diabetes all feed into each other. They're all interlinked. It has been shown that there's been less of an activity for people to seek help if they're coming from quite a deprived as opposed to around 73% of people being more active in seeking help from least deprived areas. So there are variations in diabetes care people experience, and they have different access or they access services in a different way. As we said, people in deprived communities are less likely to use and also have access to technology. So they may be digitally excluded. As we know, in this society we live in, we're becoming more and more dependent on technology. This is quite a factor, and it limits the way in which people can access certain services. I mean, I'm sure it's not just podiatry services, diabetes services. There are other services people have difficulty in accessing. Just to point out again, the region of a patient or where they come from geographically is a risk factor for them to develop a complication in diabetes. Okay, so two factors I want to sort of focus into is ethnicity and deprivation factors. Those are the key factors that actually came out of one of the research I did recently. And as we know, ethnicity is largely a factor in the development of foot ulcers and diabetic foot complications. It's reported in many studies. Deprivation is key, that influences diabetic foot diseases. And again, I'm just going to echo the same thing. Socially deprived people have a high risk of foot ulceration, reported by, again, studies quite readily. Again, regionally deprived areas like Southwark and Lambeth, where I work in, have a huge amount of people that suffer from foot diseases as a result of diabetes. Just to continue, so these two factors, ethnicity and deprivation, increase the risk of complication and poor health outcomes. Particularly Black and South Asian people are the most likely. They come on the top list of ethnicity that suffer from greater deprivation, low education, ultimately not accessing the necessary health services that they should be. So these factors have been closely linked to undiagnosed diabetes, which are sometimes, in some cases, preventable. There are some preventable complications. If, for example, they came to see people like podiatrists earlier on for their annual foot checks before they developed a complication, or coming to us at in our emergency clinic when they've developed a little lesion, a blister, for example, rather than leaving it and delay, as Mike Edmund talked about, can ultimately lead to greater problems amputations, and risk of infection. Excuse me. Also, people with diabetes type 2 particularly are 6 times more common from people of South Asian descent, and 3 times more common among African Caribbean descent. And moreover, physical inactivity is associated with obesity, as you know, therefore leads to higher risk of developing type 2 diabetes, and it just goes on and on. It's with the risk of developing diabetes and its complications. So, as I said earlier, tackling inequality of health is vast, is huge, and you know, there's multitude of factors that intertwine and lead to inequality in access to health. Now, these are some of the things that contribute to food complications that I've just listed there, really. So level of education, we've talked about, ethnicity, key areas, socioeconomic factors, mental illness, hypertension, dyslipidemia, quality of life, gender, delay in treatment, very, very important. I mean, I do clinic at times and do research other times and sort of manage, and I see delay in treatment as key. As Mike mentioned, when patients are not seeing us in the necessary timely manner, then, for example, I saw a lady classically referred to us from primary care, and initially presented with a blister, was being treated by nurses, and she developed this 2 months ago before she came to see me. And when she came to see me, she had a great large ulcer within deep within the dermis, almost sort of bone area, and yeah, so ultimately she was delayed. Had she come to us earlier, we could have offloaded, sent it to my colleagues at the MDT clinic at the hospital. We have a close link with the acute team there, and we could have perhaps minimized the detrimental effect and the progression of tissue damage. So it's very important. And one of the things I do is also go out there and do education session for our colleagues at the acute sectors of Guy's and St Thomas's A&E, or urgent care centre as it's called now, and I go and present and explain to what we actually do. So there is a lot of work that needs to be done to increase podiatry profile, the fact that what we do. So it is also, I'm also aware, and it's also been documented, that a lot of healthcare professionals still don't know what a podiatrist does. And thank you to Dr. Atkin. You know, she's largely sort of speaking and echoed what I was going to say, really. And yeah, podiatry, I think we definitely have a place within the team, MDT team, and definitely a key to helping patients with diabetic complications and preventing escalation into leading to amputation or greater tissue damage. I'm going to carry on. So what are the solutions then to health inequality? So what are the main obstacles in accessing foot care services? You know, how can we minimize health inequalities in access to services such as foot health? How are you as listeners there dealing with inequalities in your organization? You may have, you know, you probably joined us from different organizations, different part of the country. You know, what sort of things have you got in place to minimize health inequality and capture those people earlier on before they develop, you know, great tissue damage and have an impact on the NHS? And you know, and we know that treating ulcers are very costly, dressings are costly, it's costly to the patient, coming to see us weekly, you know, taxi rides, really coming down to personal level. People can't afford, so a lot of people are quite deprived, and with the cost of living, as we know now, and the fact that one of the things I would also mention is that within our service, I've worked within the NHS for about 25 years, and I've seen the changes. I joined when there was sort of PCTs from GP fund holding, and commissioning has ever changed. And the fact is, you know, inequality exists, and people are not accessing the health care they need. You know, so how are we dealing with that? Okay, so questions I'm going to throw out there to you. Some of the things that you may be perhaps included in health promoting to limit health inequality, you know, things like targeting underrepresented groups, such as I mentioned, in Southwark, you know, African Caribbean groups, Bangladeshi groups in Tower Hamlets. So they've successfully sort of captured and sort of run a regular health promotion sort of scheme there. You know, how are we engaging our public there? You know, can we hold fun days? Can we go and participate in certain festivals? Can we survey our users? Online forums. These days we can use quite readily blogs, you know, e-panels, things like that. So the question is, you know, what are we doing to tackling health inequalities and minimizing people developing greater tissue damage in diabetes, and leading to greater rate of amputations? So I'll just throw it out there. Is there any questions in the question and answer session, or is there anything that you want to?
Yes, thank you very much. No, there's a question here from Eleanor Wenburn, which says, do you do root cause analysis for every diabetic foot amputation and give feedback to healthcare professionals or services involved? And is it correct that most preceded amputations are preventable?
Absolutely, absolutely. We do root cause analysis. It's quite methodologically. We look at it with a fine-tooth comb, and we identify areas of development that are missed. Also, for example, time is a factor. So, you know, referral patterns we look at. Certain root cause analysis has led to us going back to our access, looking at how people access our service, to make sure our referral, our application forms are easily accessible. We're on electronic. We accept electronic forms these days from GPs. So we make sure we go in and liaise with our primary care colleagues to make sure they don't have, you know, so that we can identify if there's any obstacles that they have, and not being able to reach us quickly. So yes, we do root cause analysis, and the outcomes we such as learning outcomes, we do, you know, talk to the relevant people to make sure that it doesn't happen, and sort of we routinely run education courses for healthcare professionals. And I myself would go and sort of show myself and present within our primary care team meetings as much as I can, and do sort of delegate tasks to junior staff as well. So we do this quite regularly. Thanks for that. And root cause analysis is quite a valuable tool, learning tool for us, and we certainly do that, yes.
Lovely. And then a question from Leslie Raven, who asks, how much research on the patient's understanding of health education has been included in your research when looking at factors that cause diabetic complications in patients from deprived areas?
How much, what was that research? How much education?
Yeah, so how much of the patient's understanding of health education has been included in your research?
Right, that's clearly is one of the areas, is one of the barriers, basically. I have to say, language barrier. We've had certain cases where we've had to use translators to be able to put across our information and educate the patient, and it is a problem. You know, one of the way we tackle this is, I identify, one of the tasks I'm actually doing now is identifying key groups within our social groups, within our area we work in Southwark, and identify cultural groups, and we go in and target particular groups and present our service to them with the help of translators if necessary. There are community leaders we've got access to who will speak in their language. So we are targeting at grassroots levels to those people that are essentially having difficulties understanding some of the information we're putting out there, or understanding what podiatry do and how to access services. Definitely needs to be more work done on this aspect. Absolutely, education of the patient is very important, and is challenging, especially in a multicultural area. Yeah, absolutely.
And then finally from Zach, do you have a hot foot open clinic?
I'm not sure exactly what Zach means by that, but we do hold a 3-day so-called emergency clinics, open access to anybody. We'll see anybody from any area. We have people dropping in from, we work in South London, from North London, for example. As a one-off, we won't turn away people. As it's open access. It's an afternoon session. It's a walk-in. Basically, it gets very busy at times. And yes, we do have open access. So if people, for example, had problems with accessing our service, and there is a sort of a wait when we triage certain applications and put in a risk access category. If people can't wait and they've got a problem, diabetic or somebody with a really painful condition, they can come straight into our emergency clinic and we'll see them. So, Zach, I don't know exactly what you mean by hot clinics. We do have emergency open access clinics.
Yeah, lovely. Thank you ever so much. I think that's answered just about everything. I had one question which probably I can answer. Does the inequality framework change the introduction of ICBs on the 1st of July? I think the inequality framework, which ran from, I think it was 2016 to 2020, is sort of continuing, in as much as integrated care services, the focus is very much on reducing variation. So I think that's going to be the direction of travel with that. And I think we've answered the questions there. So thank you very much.
Thank you very much. Thank you, Richard.
And so if we move on, we now have a couple of abstract presentations. The first one, Foot Emergency Action Team, or FEAT, F-E-A-T, Managing Diabetes Foot Complications in the Clinically Vulnerable During COVID-19, a presentation by Jess Bolton at the Dorset Healthcare University Foundation Trust.
Hi, I'm Jess Bolton and I'm a specialist podiatrist at Dorset Healthcare. I'm here to talk about how we manage diabetes foot complications in the clinically vulnerable during COVID-19. As the country went into lockdown in March 2020, we were faced with the dilemma of how to provide care for our most complex diabetes foot clinic patients while shielding them from the risk of COVID-19 infection. The Foot Emergency Action Team was set up. 3 specialist podiatrists from the diabetes foot team visited these patients in their home with remote support from consultant diabetologists, vascular surgeons, and advanced and consultant podiatrists. Treatment plans were put in place to manage these patients without them attending the diabetes foot clinic, and these were the 4 aims: to prevent hospital admissions due to foot complications, prevent avoidable amputations, prevent avoidable deaths from diabetes foot complications, and enable these complex patients to shield from COVID-19 as per government guidelines. It was developed within 1 week of lockdown being announced. The patients are split into 3 caseloads by geographical area. 3 specialist podiatrists were given a caseload each to manage. They co-covered each of the caseloads for annual leave and sickness. This worked very well and there was good communication within the team. It took pressure off the community podiatry service while it was suspended and helped support and take pressure off the district nursing teams. It was liked by the patients as they were seeing the same podiatrist, which provided continuity of care. It built good relationships with them and also the local district nursing teams and GP surgeries. During this time, we had a caseload of 34 patients, 23 were male and 12 female. We used a SIMBAD classification system, which is recommended by the IWGDF to grade the severity of the ulcers. 85% of patients had a SIMBAD score of over 3, which reduced to 50% by the end of the feet visits. 20% of ulcers healed and 29% had an improved SIMBAD score. Some patients' SIMBAD score wouldn't improve while they had an active foot ulcer. For example, someone who had a neuroischemic ulcer on the heel would always score 3 out of 6, no matter how much it improved. There were 6 deaths, none foot related, and 1 due to COVID-19. There were 10 admissions, 1 for sepsis, which was picked up on the patient's first feet visit, 1 for below-knee amputation, which in this patient wasn't unexpected. There were no minor amputations. The reduced amputation rate in this complex group of patients follows the trend in England during this period. We had to make a number of changes to how our service operated during COVID-19. Some of these have continued as they've been shown to be very effective. Previously, all diabetes foot ulcers were managed within the multidisciplinary diabetes foot clinic with shared care from community podiatry. Clinics were often saturated with little flexibility to offer emergency appointments when required. During the initial lockdown, the more complex patients with severe ulceration were managed by the NDFC or feet visits, and the less severe ulcers were managed by community podiatry. There is seamless transfer of these patients between community podiatry and the MDFC depending on ulcer severity. This has provided greater service flexibility to see the more complex patients in the multidisciplinary diabetes foot clinic. We have continued with remote advice and guidance from the advanced and consultant podiatrists. Photos can be uploaded and a discussion can be had either over the phone or via email to form a management plan about the patient attending the diabetes foot clinic. In conclusion, the feet visits were an effective way of providing a high level of holistic diabetes foot care in the patient's home, helping to prevent hospital admissions and amputations, whilst also protecting them from the risk of COVID-19 infection. Thank you for listening.
And thank you very much to Jess and the team at Dorset for that presentation. And now we move on to a presentation from Torbay and South Devon NHS Foundation Trust regarding Connect Plus, a patient-focused interactive education app for people at risk of diabetic foot disease.
I'm joined by 2 of the podiatry team at Torbay and South Devon NHS Foundation Trust, Richard Collins, the podiatry team lead, and Jem Williams, one of the advanced practice diabetes podiatrists. Richard, Jem, why did you set out on this journey that originally, was quite traditional, but why did you set out on this journey?
As a team, we're always trying to advance what we're doing. And one of the things that we kept coming up against was patients weren't doing their self-care or following the advice we were giving them at home. And we wanted to investigate why that was happening. And one of the aspects that we looked at was the patient education. And we did a survey of our patients looking at what their education levels were around their foot care and their diabetes. And actually what we found, there were some aspects of their education and their knowledge about their self-care and their disease that weren't as good as we would expect from the education that we provide. So that then led us on to investigate that further with patient groups to discuss our current education, or our education package at the time, which was very traditional. It was verbal advice in clinic, followed up with some quite bland black and white leaflets that we would give out. And really what we got back from the patients was that didn't work for them, and they really wanted us to look at different ways in which we could engage with them. And one of the ways that was suggested was around Facebook closed groups, and that kind of developed into looking at different apps that were available. And at the time there were no real apps available for diabetic foot. From that, we were doing patient videos with HCI for MSK and nail surgery, and then it really just progressed from there.
I think, echoing on from Jen's point of view, is that for us to redesign our services based on what patients want, rather than traditionally we do unto you. Actually, what do the patients want? And I think that was the change in theme from us, is that actually the feedback from the patients was very clear, and it's how then we can facilitate what the patients want.
It was a series of videos that the patients could watch in clinic and then watch whilst they were at home, so they had a good reminder of what they were meant to do. And then the MSK team did quite a lot around stretching advice, so that their patients could go away from clinic and they had a video that was on our trust website, and they could access that whenever they needed to refresh their memory on what they were meant to be doing. We wanted to do something for diabetic foot, but it's very complex, diabetic foot, and actually it contains all sorts of different topics. So the app provided a really great platform to be able to put all that information together. New videos on diabetic foot, as well as the stretching advice and the nail surgery advice, and we're able to collate that all in one area, as well as provide written text and links to other sites that may be helpful, and information about the team, where the clinics are, how to get hold of us, what to do in an emergency. And that was really the first phase of the app as it was launched. The information we used to provide originally, it was not interactive, it was quite bland. Although it had the Torbay logo on the front, it was very generic, and this really does allow them to feel like it's targeted for their population. They've got all the information about the podiatrists and about where we all work. And I think that really allows them to feel that it's their app. We've added things like symptom trackers, so they can track their pain. They can record their own personal risk factors, diabetic foot risk status. So if anybody asks them, they've got access to that quite quickly. It also allows them to upload all their medication, track when they're meant to be taking it. So if they are on antibiotics, they can have that information to hand when they come to clinic.
We used to print off realms of leaflets. We're not doing that now, where we can give one single with the information for the app, which then means that we're not wasting paper. Clinicians have more time. And I think clinicians can then focus on trying to get the patient to start to self-manage. We're empowering the patients to take more responsibility for their care. From a clinical point of view, we find it really easy. Clinicians find it really easy.
Thank you both for your time today, and keep going, I think, for the benefit of the trust, but most importantly for your patients. Thanks, everyone.
Well, thank you very much to Richard and Jen for the presentation, and the team at Torbay. So we come to a conclusion now, and my word, we've had a very interesting afternoon. We've covered integrated lower limb care. We've covered the really important role of the psychologist. We've covered the changes that are happening with integrated care services in the NHS. We've had a very thought-provoking talk from the patient perspective, a wonderful debate about the absolute need for podiatry, a discussion about inequalities, and then some ideas about digital solutions for education. Absolutely wonderful. I've got to say, the English Diabetes Foot Care Network, we're not just here once a year. We are available online. The website is edfn.org. Please come and join up. There are some really useful tools on there that we're creating. We already have a peer review for foot protection services and also a peer review for multidisciplinary foot teams. They are free, they're available to you, and if you respond to us online, then we will start to collate some high-level information to work out if there are similarities in issues around these various peer reviews. I would like to thank all the speakers from today. It really has been extremely good, as well as our guest chair, Derek Thomas. I would like to thank our sponsor, Dermatonics, for helping us put this meeting together. And also the EDFN is supported by the Royal College of Podiatry, thanks to them. And thank you to OJ Communications, who have made this run very well, very well. No glitches. It's been wonderful this afternoon. Thank you all for attending, and I wish you a very happy and peaceful bank holiday. Goodbye.